No, enrolled. Oh no, you have to introduce him, don't you? Oh, and then you, and then else goes. Oh, I need a pen. No, you'll need it. You need some on the table.
We'll have some.
Yeah, no, no. You go first.
Yeah, exactly.
Good morning, welcome. Thank you for joining us on this early Sunday morning. It's a great dedication. We're just waiting to bring our other moderator online and we'll get started.
Dear colleagues, ladies and gentlemen, welcome to the CEVHAP Symposium in APASL 2023. Viral hepatitis is a major cause of advanced chronic liver disease and is also a leading etiology of hepatocellular carcinoma. In 2016, the WHO Global Health Sector Strategy on Viral Hepatitis provided the initial roadmap for the elimination of viral hepatitis as a public health problem by 2030. Currently, the WHO is helping different countries to develop hepatitis control programs and to avoid liver cancer. However, a number of countries still have difficulty to achieve the WHO's goals to eliminate viral hepatitis, particularly in Asian region. In this symposium, the CEVHAP bring together investigators from all over the world to exchange their knowledge and experiences. I believe everyone who attend this symposium will have a fruitful harvest. Thank you for joining this symposium.
Yes, yes. You need to.
Many thanks to APASL President Professor Lin for your warm welcome, and to Professor Dai and the APASL Operating Committee for your help in making this symposium a reality. Thank you also to our second partner for this symposium, the World Hepatitis Alliance. Carrie James, Jessica Hicks, and your team, thank you for your valuable contribution. I would also particularly like to thank and recognise our two sponsors, Roche Diagnostics and Gilead, for their support. Events like this simply wouldn't be possible if it was not for the funding we received from our sponsors. This is CEVHAP's 14th year in operation and our 13th symposium held jointly with APASL at their annual conference. Back in 2010, two remarkable leaders in science and hepatology, our co-founders, Professor Stephen Loccanini and the late Professor D.S. Chen, saw the need for an independent voice in Asia Pacific to push governments to do more to pave the way for access to new therapies for viral hepatitis. And so the Coalition to Eradicate Viral Hepatitis in Asia Pacific was born. Professor D.S. Chen was adamant when WHO introduced its elimination goal that we retain Eradicate as our long-term goal. As we all start to emerge from some very tough years through the pandemic, it is quite fitting that we should be here in Taipei, where the wonderful Professor D.S. Chen was so instrumental in Taiwan being at the forefront of policies and measures to assist people living with viral hepatitis. Alongside that important, indeed central objective of the APASL conference, to advance the science and practice of hepatology, we can pause to think about and identify all the other things that need to occur around the scientific development and medical innovation in hepatology if those living with hepatitis are to benefit from new innovations and practices. While much has been achieved across the region and globally, there are still significant gaps, particularly in the Asia-Pacific region. The APASL organisation and we at CEVHAP are dedicated to the interests of those with hepatitis who are located here in the Asia-Pacific region. Too often, for whatever reason, we see, for example, global conference agendas that are not representative of the fact that roughly 2/3 of those living with hepatitis reside in this region. That really does need to change if we have any chance of achieving the WHO goal of hepatitis elimination as a public health threat by 2030. In today's symposium, we will look at 3 areas of viral hepatitis infection from the perspective of the lived experience. Firstly, we'll hear from 4 people living with hepatitis about how their diagnosis has impacted their lives. We'll hear from the promising developments in immigration practices in Australia, some policy recommendations to address stigma and discrimination, and developments in human rights law in the Philippines. In session 2, our keynote speaker, Craig Kramer, will present a global perspective of the mental health crisis and talk about some ways we can help ourselves and others affected. Other speakers in this session will talk about the mental health impact of a hepatitis diagnosis and the value of counselling and education, especially the benefits of involving the whole family. The common thread in the final session is that of access and service delivery within the broad context of place. As we talk about prospects of a cure for hepatitis B, what does that mean for patient access and service delivery? As we know, hepatitis is the major cause of liver cancer in Asia Pacific. How does the place where you live determine the treatment you receive? And if we are to see real or functional cures emerge for hepatitis B, are we ready? Are governments ready to provide access to new therapies in this region where over 70% of people live with hepatitis B? We're delighted to bring this symposium to you and now pass to our opening moderators for session 1, CEVHAP co-chair, Professor Rosemawati Mohammed, and CEVHAP Executive Committee member, Dr. Jack Wallace. Thank you.
Thank you very much, Jenny, and a warm welcome to everyone to this first session on paradigm shifts in stigma and discrimination. So without doubt, I think what has been really highlighted by Jenny, stigma and discrimination have been identified as one of the key barriers to the WHO target of eliminating viral hepatitis by the year 2030. So we will start this session with a series of personal stories from the lived experiences. So there will be video presentations featuring 4 outstanding advocates. They are Lian Tran, who is the co-founder and director of Hepatitis B Voices Australia. We will have Dee Lee, who is the director and co-founder of Inner Community Development Organization. We'll also have Associate Professor Thomas Tu, who is the president of Australian Centre for Hepatitis Virology and founder of Hepatitis B Voices Australia, and also Professor Jackie Chen, a Hepatitis B patient and advocate and founder of Taiwan Hepatitis Information and Care Association. So can we please show the videos?
In 1989, I came to the US from Taiwan for my PhD studies. After I finished my degree in 1992, I got a call from my sister. She said, "Our brother is in the hospital, you need to come back." That's when I found out he had liver cancer caused by hepatitis B. He was infected when he was born. I wonder, am I also hepatitis B positive? I got tested and learned I do have the virus. My brother started treatment for liver cancer and hepatitis B. Later, I got treatment for hepatitis B too. Later, we found out my wife also has hepatitis B. When she got pregnant, I thought, how can we protect our next generation? We researched and got her treatment with antiviral during her last trimester. This, together with the hepatitis B vaccine and immunoglobulin, successfully protected our son. As years passed, we wanted to help other families as well. So we set up a Taiwanese hepatitis patient group. We help answer patients' questions and make sure people get the treatment and support they need. My brother has been cured for 10 years. This is rare for liver cancer. I feel so grateful to him because if he hadn't got through what he did, I would never have known I have the virus.
So I was diagnosed with hepatitis B when I was at college, and by that time I was studying in Vietnam, and I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. I had no idea about hepatitis B, and the only clue that I had by then was that it relates to the liver. And because my grandmother died of liver cancer when I was 6, so I made the direct relation, I'm having liver cancer and I'm gonna die, and I'm gonna die soon. And then I had to reject the scholarship just because he told me so. I was born in a village, and no one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam in early 2000. So getting to know that I would not be able to go there is bad. But actually it's not the worst part. Like by then, because I thought I was dying, so not being able to go overseas to study was not a big deal anymore. And then I went back to study. I kind of forgot about that because I was too busy studying. And then I remember at some point, suddenly I was surprised that I haven't died yet. So I started to go on the internet to learn more about that. So by that time, I didn't have a computer. So there were a bunch of cafe internets nearby the uni that I studied. So I spent money there. The fee for accessing internet for an hour is actually equal to 1 meal. So sometimes I thought, okay, I don't know how many lunches or dinners I have to spend to know that I can live a normal life with happy, but not only dying with that.
A lot of the talk has been about the community pushing that stigma and discrimination. As someone living with hepatitis B, before any of that can affect me, I've already done it myself. That self-stigma comes first and comes straight at that moment of being diagnosed. I'm someone that is ashamed, and all the values and burden associated with that infection is reflected in myself, in my own thoughts. And that's very difficult to overcome because the very nature of it means I can't talk about it very easily. And it combines with the community silence about hepatitis B that surrounds hepatitis B. It's very difficult to talk about it openly because no one's talking about it. And from those personal experiences, I knew exactly what needed to be done is to form a community, form those connections so that people with hepatitis B can share these experiences and discuss and talk about ways of overcoming them together. And one thing that has been very surprising to me is that no matter where people are, no matter what kind of communities they're in, they have felt the same experiences as me, that self-stigma, first and foremost.
I am a hepatitis B carrier since at the age of 2. It is rumored that you can easily get hepatitis B easily by shaking hands, sharing utensils, hugging, and maybe through air. So when we come back to the workplace, things are even worse. And especially during the lunchtime, there's a particular table with a flag saying that happy table. I found a job totally suitable for me. It's a public relationship manager in a apparel factory. At the end of the interview, they say you have to hand over your body examination, claiming that you have to be a person without hepatitis and HIV/AIDS. But on the contrary, I'm a happy carrier. But I really want a job. I asked a very good friend of mine to come to take my place instead, to say, but as a PR manager, I am the person who helped the factory managers and boss to organize this happy table one by one. I was supposed to be in that table, but I'm become the person who exercised this crime against human rights. And I feel ashamed, I feel guilty, At the end of the day, I quit the job. I started to think about, what I can do to change this scenario. By meeting so many hepatitis carriers and patients, you can easily have a very strong feeling that these patients are just like warriors. If I'm going to select only one word on the elimination of hepatitis 2030, that would be bravery. Bravery it is.
Thank you very much for all four for sharing your personal experiences, and particularly on the stigma and discrimination. So I'll pass to Jack to introduce the next title.
Thank you, Dros. My name's Jack Wallace. I'm an executive member of the Coalition to Eradicate Viral Hepatitis in Asia Pacific, and I just found that video so impressive and such reflecting hepatitis as a human rights issue, not only a medical issue. And I'm deeply grateful for the people who disclosed and shared that information. And we're coming back to Leanne, who was one of the presenters in that video, who's going to be talking about hepatitis B migration to Australia and recent positive developments in that. Over to you, Leanne.
I came to Australia in 2008 from Vietnam to study nursing, as a plan to stay permanently in Australia. During the time I did nursing, I had to do placement and had to provide my immunity checklist. That's why I found out I got hepatitis B. And when I graduated in 2011, I decided to study more to find to find another way as another plan if I had to change my plan after nursing. Also to help improve my points for my permanent residency application in the future. After I graduate, the further study, which was myotherapy, advanced diploma of massage therapy, with a remedial massage therapy. I put my information up for expression of interest for permanent residency as a nursing pathway. Eventually, I got invited for nursing pathway permanent residency in 2014. At that time was the time that I finished doing my massage study. And it was a turning point where I had to decide which pathway I should follow because of hepatitis B and other issues that arise since I got the hepatitis B. And I learned from the health department. I learned from the visa of what's that called? Home Affairs. Was that called Home Affairs?
Department of Home Affairs.
Yeah, according to the Department of Home Affairs at that time, what I read was nursing is a threat of public for permanent residency, and nursing and other health professional to apply for permanent residency. And that was the thing that put me off from applying for permanent residency. Eventually, I decided to follow the remedial massage myotherapy pathway that I got sponsorship for work in Melbourne. And I went for that pathway instead, which was the visa 457, and then 2 years later, I got nominated for permanent residency visa 1 subclass 186, and I didn't know that visa. Because I thought that when I got sponsorship, I think it would have better chance for me to pass the process of permanent residency. But when it came to health assessment, they told me that my health would cost the government, the Medicare, it's like a huge amount of money, and like more than $300,000 if I was to stay for up to 85 years, and then they gave me a form to fill out for the health waiver, and the form include a lot of questions more about what I've been doing in Australia. So like it's more about how much I worth for Australia to take me, even if I have that health condition. And at that time, suddenly my viral load got my viral load decreased to a level of 20, and it was the one time that it come down to that number, and normally it's very high, and then I sent that result in and I got the PR. So I got become Australian permanent resident in 2017. That was like around 1 year in the PR process. Okay, thank you very much. So it gives me great pleasure to introduce the next speaker. It's Carrie James, who's the Chief Executive Officer of the World Hepatitis Alliance, a global network, I think known by all of you here, of community-led organization in about 100 countries. So Carrie is also the steering committee of EHC 2030. So today, Carrie James will be talking about World Hepatitis Alliance white paper on the impact of stigma and discrimination affecting people with hepatitis B. So this is from the policy response. Over to you, Carrie.
Thank you. Just 1 second with my slides. Thank you. Thank you so much. Thank you. And thank you for the invitation to be here today. Thank you for everyone who's been sharing their stories so far this morning, because we know the power that that has. And I think what Thomas said about the kind of silence that surrounds hepatitis B and how that makes things so difficult in so many ways for the individuals, but also to create changes in policy and in kind of medical guidelines. And on the screen, you'll see a report that we did at the end of 2021. And in this paper, we really wanted to explore this kind of connection between the personal experiences of people living with hepatitis B and the policy changes that needed to happen in order to improve their lives and improve the lives of people around the world. And you'll see, if you look very closely, I don't know if I can use the laser pointer, some of the faces of the people that you've just seen in the videos before, Leanne and Dee, and maybe we'll hear some more from them later. So here are just some of the stories that they shared. I won't read Leanne's because she's just talked about it so eloquently herself. But Faisal is from Bangladesh. And he said, "I never expected this to happen to me. I am still unemployed and feel hopeless, knowing that any company will not hire me based on my hepatitis status." So I think this kind of discrimination in the workplace is something that Dee really spoke about very powerfully in his video as well. Another story from Sydney, who immigrated to Australia, a bit like the story that just came from Leanne, but I was given a deportation order based on my hepatitis B status because the government decided that my treatment would cost the health system too much money. I knew other people living with hepatitis B that got their permanent residence, with the only difference in our case being that they were not taking medication. Therefore, they were not seen as a burden to the healthcare system. The government saw me not as a person, but as an expense. And on the top is a message from part of the statement from our current president, Danjuma Ada from Nigeria. It says, "There's a sense of shame and I faced a lot of pressure. The diagnosis really affected my confidence and my mental health." So you're getting to see just by what we've already seen in these videos and those quotes, how far-reaching stigma really permeates into people's lives and into our society, into our health systems. And just the only other interview I'd just like to point out was this one by Professor Locke, who's obviously very well known in the region that we're in today, really talking about the discrimination faced by medical students and within the medical establishment. So based on the interviews that we did, we really wanted to link the experiences that these people had and the challenges they had and provide policy recommendations in order to address them. So the first two policy recommendations are really about at the beginning of a patient's journey when they find out that they are living with viral hepatitis. So the first one is to provide accurate and accessible information regarding hepatitis B for those newly diagnosed, including transmission, health promotion information, rights and responsibilities, and a long-term health plan. And I think we can see the impact of people not having proper information when they're first diagnosed. You look at Leanne's story, how she missed an opportunity to study abroad, how she had really unnecessary anxiety around the risk of death at that point in her life. So, it's really important that we make this a priority, that when we do diagnose people, that they're given the information and the skills that they need in order to navigate mentally through the diagnosis, but also through the health system. And one big part of that is to ensure that all newly diagnosed individuals are linked to appropriate and supportive healthcare services for their ongoing and management. These three, or at least the next two, are more about specific issues. So ensure equitable and affordable access to prevention of mother to child transmission programs for all women. I think that's kind of self-explanatory. Ensure that mental and emotional support is provided to people diagnosed with hepatitis B and their families, because it's not just a biological or physical diagnosis. As we've seen in those stories, it has a very big impact on how people see themselves, how they see their roles in their families and in societies. And many people live in silence with mental health problems and depression for many years. So it's important that they get the support that they need from the very beginning, and also their families. And the third one on here, again, kind of addressing what Professor Locke was talking about in her interview, require all healthcare professionals receive ongoing hepatitis education and are aware of stigma and how to address it. And this is not only talking about doctors or hepatologists, this is also talking about clinic staff, about nurses, because people living with hepatitis B need to feel safe from the moment they walk into a healthcare facility, that they won't be judged, that they're going to receive the support and care that they need. And the final two, ensure testing for hepatitis B is conducted in the context of healthcare services, that the results are confidential, that the testing is of direct benefit to the person being tested and is not required as a condition of employment or education. So really the whole testing process and getting the result is for the benefit of the patient, and shouldn't be coerced or should not be forced by any kind of, exactly what it says, condition of employment, education, or any other means. And finally, ensure anti-discrimination laws and policies are correctly implemented and that adequate recourse is given to enable people experiencing discrimination to pursue justice through the legal system. And I think this is really important in places in the world where there are still discriminatory laws against hepatitis B. I mean, it's 2023. It's time for these to be off the books, everywhere around the world. And I think actually it might be two more, sorry. There's two more also pertaining to this. Ensure there are legal protections in place for people with hepatitis B, including protection from government-sanctioned discrimination. And finally, ensure that immigration and visa policies do not limit the freedoms of people living with hepatitis B because of their diagnosis. So we feel that these are things that on a very practical health systems, society, and governmental standpoint that can be done to help address stigma and discrimination for people living with hepatitis. And we really hope that these will be taken to heart by health systems and by decision makers to really make the lives of people living with viral hepatitis around the world better. So thank you very much. If you want to see the full report, it is on our website, and thank you for your time.
Thank you, Kerry. That was wonderful summary of the WHO work that's been done. Thank you. Now, next we have Chris Munoz from Philippines, from Yellow Warriors, and Chris is also a member of the executive of the Coalition to Eradicate Viral Hepatitis in Asia Pacific. And we'll hand it over to Chris.
Good morning, good afternoon, and good evening. I'm Chris Munoz from the Yellow Warrior Society Philippines. I'm their current advisor. And thank you for inviting me to talk about fighting for the human rights in the workplace and its current status in the Philippines. So Yellow Warrior Society Philippines was formed around 2009, and it was formed of people or patients, not because they were looking for a cure, but more they were bonded together because most of them, if not all, were rejected when they were applying for a job. So, the community grew as it passed by. And in 2010, so that time they approached Senator Pia Cayetano, whose father also passed away because of liver cancer. He also had hepatitis B. And they found an ally, with the person of Senator Pia. And she, called for a Senate hearing for the creation of a hepatitis B technical working group. So during that time, she called upon the Department of Labor to look upon it, on what was happening, and create solutions for it. And because of that, Department of Labor and Employment issued guidelines on workplace policy and program on hepatitis B. So it was not a law, but more of a Dole Department Advisory Number 5 series of 2010. Its purpose was to guide employers and workers in the formulation of a workplace policy and program on hepatitis B. So it is a requirement for all private institutions, for all employers to implement a rights-based policy and a program on hepatitis B that incorporated human rights standards and principles. So it was this kind of policy only covers the private sector. It doesn't cover the government sector at all. So during that time, there were also many applicants who were denied when they applied to the military, to the army, to the Philippine National Police, those who want to enter the Bureau of Fire, or those who want to serve in the jail, and and they were not given a chance because the policy was that an applicant has to be screened, and after that, when found positive, just like in the private sector, they were denied already. So during those times, usually it was the government, not all, but some government institutions who screen. In the private sector, it was usually the multinational companies or the international companies who screen applicants for hepatitis B. So it was really not that popular during that time. It was just unfortunate because most, the community was composed of, engineers, those who want to be nurse, to be doctors, to be teachers, those who want to serve in the government institutions. And we thought that by raising awareness, so we can inform, more people about it, to get tested, to know their status. And at the same time, we were hoping that employers or HR practitioners or, those who craft policies in their companies, that they would understand and not screen applicants for hepatitis B. Or if ever they opt to screen applicants for hepatitis B, they would get referred to a doctor, because during that time there was still no cure for hepatitis B, and the treatment was very expensive. So at the very least, they could get a medical clearance to protect employers, just to know that this applicant has been tested for hepatitis B, but his current status is that he can get employed, he can do the work, just like any other applicants. So moving forward, we are now in 2023. So instead of having more companies to understand about hepatitis B, and instead of them not, giving the hepatitis B as a screening as a requirement to their applicants, we see that even companies or agencies whose business model is about giving service to families, giving drivers, nannies, or those agencies who supply workers to local companies or international companies, they still couldn't get or understand what hepatitis B is all about. So you see here, this one is 2021. It was during COVID season. So they're saying that, despite of the applicant passing her COVID-19 rapid antigen test, he got tested positive for hepatitis B. And they were hoping that she can go back again and present a negative test for hepatitis B. So they're telling that their clients that they are doing their best to screen healthy maids for the Filipino family. So mostly people or nannies or drivers, usually these are people who didn't graduate in college, and they were hoping to get a job to be able to earn and send money back to their families so that their children can go to college or go to high school. And it was very sad, seeing that up to now, more instead of companies, not screening applicants for hepatitis B, we see more and more local companies screen applicants for hepatitis B and reject them right away, not even telling them, oh, you need to go to a doctor and you just get a clearance. If the doctor gives you a clearance, let's say a class A, that you are fit to work, then just come back to us and we'll give you an employer so you can work right away. So until now, COVID has passed. As you know, we're done with the COVID already, but for hepatitis B, unfortunately, it is still there. So during these past few years, we were talking about, having legislation, a law that would prohibit employers from screening. And it was really a challenge. We were inviting senators when there is a symposium or, when there is an event, and they would always show their support, and we didn't hear anything negative about it. They agree that companies, people should not be discriminated because of their status, that they should be given equal opportunity to get employed. But unfortunately, up to now, we still doesn't have any bill, because even the Department of Labor told us that the best way is to have a law, that could prohibit companies from screening, and it would be easier for them to act on it. So our next step was that if nationally we couldn't get a law enacted, where we turned into the local government units, and they can pass their local ordinance. But of course, how many cities you have to cover, how many times you have to explain that we need their support, that we couldn't get a national bill passed. But if they have a local bill, at the very least, their constituents would be protected. So the first, city that passed anti-discrimination law was Davao City, because during that time, the president was from Davao, and her daughter was the mayor of Davao. So the city council, there was already an anti-discrimination law, but it didn't include or include a health, or it didn't include any status, hepatitis B status in the law that would prohibit employer from discriminating those applicants. So they included it in 2012. They passed it, and it sent a strong message, and we were aware of that companies would comply, because after that we somehow saw that our members from Davao wouldn't get screened for hepatitis B anymore. So it was something that we can bring, and we always show it to other municipalities or LGUs that Davao has already implemented their anti-discrimination bill, or gave protection for people living with hepatitis B, and hopefully that you can also do the same. So this was passed in 2012, and I think 2011 they were already thinking of ways on how to do it, and if it is really warranted to be done. So as you see, before it was only there were no health status, in that policy, and they included anti-discrimination on health status, and they also included the membership of City Health Office, LGBTQ++, and gender, and this strengthened. It really has an effect to their employers. So there were champions in the Senate. So one of them was Senator Risa Ontiveros. She was the first senator to make a bill. They called us and they told us, okay, you present us a bill, and what do you want to happen? So she filed the bill, but unfortunately, it wasn't even read, because it is a process. It was not a simple thing that when you filed it would just get approved. So the next was Senator Bongo. He also filed this policy, or a law, an act instituting a policy on blood-borne viral hepatitis testing and screening. It is almost the same, the main purpose was to tell employers that you should not screen for hepatitis B unless the applicant may be working in an exposure-prone activity.
Chris, can you wrap it up? We do have limited time available for us. Didn't think that was going to happen so suddenly. My apologies. And so we have a panel discussion. Oh, Chris, there you are. Thank you.
I think that was a video.
Okay, beautiful. And okay, so we have a panel discussion. Can we get everybody online? And Jackie Chen from Taiwan is joining us on the podium. And beautiful, thank you. Now, are there any kind of questions or those that session this morning, this session this morning just reminds me of some very fundamental things. One of the key issues for me in the global response to hepatitis B is that only 10% of people are diagnosed. Now, these presentations this morning have given really good reasons why that number is so low, why the number of people accessing treatment is so low, and it gives an absolutely beautiful rationale. Now we have Bob in the room who would like to ask a question, make a comment.
This is a fantastic session. I get so much education through these. Thank you very much. This is a question for Jackie about Taiwan and Taipei. What are the regulations in this country about hepatitis B people working in the food industry or restaurant, for example?
Wow, excellent question. I'm probably not be the best person to answer this question because we have, I don't know if Dr. Dai is still here, but from what I understand, I might be wrong. I have to say that first because I'm not, I haven't been here for many years. But from what I understand is that there's no restriction at all nowadays, except if you are working in the food industry, you might have to be tested, all right, and make sure that you don't have Hep A, for example. And
Great.
for Hep B, I think it's not an issue. It's forbidden to be even tested. You're not supposed to ask a foreign worker from Philippines, from any other country, when they come to apply for a job, they shouldn't even be tested for that.
Great.
That testing is a kind of a form of discrimination by itself. And that has been, from what I understand, that has been eliminated by law.
Fantastic.
And Bob, that raises an issue for me also, is that one of the things is that within this region is that there are some countries in which stigma and discrimination related to hepatitis B does not occur. So I get really scared when we talk about it as a blanket issue across the region. It's actually not true. We need to be a bit nuanced about it. But that question about which country, in which countries is stigma regulated is a really important kind of point that we need to kind of get resolved at a regional and global level.
Thank you.
Maybe I can add one thing that we interview with Hep B Foundation. We interview many patients here, 12 of them actually. And we asked this question. This is asked by Hep B Foundation. They want to know what's the stigma, what's discrimination there. And they said totally in opposite. It will shock you. It was said totally in opposite. The reason they don't want other people to know is that everyone want to offer help and help and opinion and suggestion, and they just overwhelming support for them. So, and they want to have a more peaceful life. So instead of being discriminated, it's on the opposite side.
Should we create a global scorecard on hepatitis B and maybe hepatitis C and actually give it country by country status?
We haven't got one and we need one.
Oh. Well, we're actually working on a hepatitis stigma index, a global index, which would begin with, like a seance or something. The spirits are here. Which would begin on a country level. So we would create a measurement instrument, and then we would implement it in a few countries, and then eventually we'd like to build it out. But I think there has been some great work done by Hep B Foundation around discriminatory laws and globally. So I think it's kind of pulling all those things together, making it really accessible so we can shine a light on governments who are discriminated against people with hepatitis, and also the experience of people within society as well, because that's not always reflected in the laws or in the statute books.
Thank you.
Thank you.
Now we have 2 minutes.
Okay, so I just want to bring out the point that Chris Munoz has been talking about. A lot of our population goes to the Middle East for employment. and there is that summary dismissal if they are hepatitis C surface antigen positive. They're not even sent to a physician to understand what their disease is, what is the status, are they transmissible or not. They're just dismissed. And we have been talking about this for a long time. Chris's work is there. The only needle that I think he's been able to move in all this time is a city law, and that's about it. So I think it's time that we need to start thinking more globally, more regionally about this. Otherwise, this will never go away. So sorry for the sense of frustration, but I think this is what the viral hepatitis field in general is faced with, a sense of frustration.
Thank you, Syed. Leanne, have you found your experience in Australia different from that in Vietnam?
Thank you, Jack. Thanks, everyone. It's great to hear different stories from different countries, and I'm honored to be able to witness that. In Vietnam and Australia, and I have to say that there are like some similarities and some differences. What I would say is that in both countries, there are both kind of like personal discrimination from people from community, wider community. But I think it is really sad that there are institutional discrimination in the Australian law system, just like the stories from people trying to migrate to Australia via the stories that we were able to collect it and share today. So I guess the discrimination and stigma discrimination range from different level, from personal, from self-stigma, as Thomas shared earlier, and I believe that we all experience that ourselves and from the community. But I think the worst part, the saddest part, is the institutional discrimination that we need to address. And the ideas of having the global scorecard, the global ruler, the global standard to, just to say that you are doing really bad in that way. Your country is doing bad, really bad. It's doing worse than the other country. I think that's also a way that every country should try to look at and make it that, oh, we are doing better, things like that.
Thanks, Leanne. And Jenny, you realise that we're...
Last question, probably, I know, Mr. Jack. But just to Dee, I can remember many years ago, probably back as far as 2005, China introduced anti-discrimination laws. But is there anywhere where it's actually being implemented?
It's a good question. This is exactly, I want to echo Jack's and Carrie's, comment on, how we can measure the whole, the index globally. And, we.
Oh, China. Damn.
We have lost the.
Sorry, I'm back. Sorry.
Yes.
Just want to run it really quick, before I got just cut off by the signal. It's well implemented on the governmental side. China is a very good example to let us know, how policy making should be done and how policy implementation should be done. But on the government side, the rules and regulations are very well publicized and implemented. It's been, on the wall, in the workplace, everywhere. But on the contrary, since 2010, so the regulation was introduced in 2010. Up until now, in the last, a dozen of years, we're still getting the cases of, being discriminated in the workplace. The people living with hepatitis could not get into the labor-intensive workplace, and as well as there are so many suicides every year just because of the discrimination in the school, in the government workplace as well. These are the areas you can see, it is not going away until we fight as a community against the disinformation and the wrongdoings. Yeah, I think that's why World Hepatitis Alliance and CEVHAP, and as well as the organization I'm representing, the IOC International Liver Cancer Movement, should be work together as a community to fight these sorts of things we don't think that is rationally existed. Thank you.
Thank you very much. I think we all had really wonderful insights from the speakers, and then especially from the lived experiences. And I think there are already suggestions on the way forward. So with that, thank you very much for the speakers, as well as Jack, the moderator, and all of you for attending this session. So we have to move on to the next session. Thank you, everyone.
I think we've had an excellent start. It has really been an inspiring first session. I just wish there were more people in the room to have listened to that. And maybe if we were in the mainstream of the conference program, we would have had more people. So, but anyway, this is a fantastic start to the symposium. So we are on to the next session, and I would request my co-chair, Jessica Hicks, to get this started.
Great, thank you, Saeed. And on behalf of the Alliance, we're delighted to be co-hosting today's symposium with CEVHAP, and really excited to be co-chairing with Saeed on this really important session on mental health, which I think is a topic that really impacts people living with viral hepatitis, but which rarely, if ever, is discussed at meetings such as this. And so really pleased that we can discuss it today. And so I'm going to invite our first speaker, Craig Kramer, who is a mental health leader, co-chair of the UN-affiliated Mental Health Innovation Working Group and the US National Action Alliance for Suicide Prevention.
We all have a mental health story, and part of my story begins on New Year's Day a couple of years ago. I got a call from my daughter, Catherine, and since it was New Year's Day, I said, "Hey, Catherine, how's it going? Happy New Year." Because I am a embarrassing dad. I embarrass my kids all the time. And then a man answered the phone on the other end, and now I knew my daughter had been on a first date the night before, New Year's Eve, so I was not completely surprised. But the man said, "Are you Catherine's father?" And I said, "Yes, yes, I am." And then the man said, "This is the Boston Police Department. Your daughter tried to take her life. We are taking her to the hospital, and you need to get up here right away." As my wife and I drove from New York up to Boston, we thought about our daughter's 10-year struggle with an eating disorder, trying to find a primary care doctor who knew something about mental illness was very hard in our country. Trying to find a specialist who had time to meet with us. It usually took months to get an appointment. And then you would find out that the specialist didn't have the skills that you needed for your particular child. In the United States, you had often your insurance, your payer, your health insurance did not cover basic mental health services. So you would have to pay out of your pocket. Often, we looked at the advocacy community and the research community and found that they were underfunded and that they were also fragmented, very small organizations. And we quickly realized that they were not going to come to our help. And mostly we thought of how exhausted we as parents were, because every night we went to bed, we did not know if our daughter was going to be alive the next morning. And that meant that we were very tired at work, and that we were having our own physical and mental challenges. And we had a hard time really caring about anything else but our child's welfare. Later, we found out that these challenges apply not just to the eating disorder that our daughter had, but they apply to all mental illnesses: depression, anxiety, addiction, postpartum depression, post-traumatic stress, obsessive compulsive, bipolar, schizophrenia. And we also found out that it wasn't just our country, the United States. The World Health Organization says that when it comes to mental health, every country is a developing country. It's really difficult everywhere. Now, at the time, I was working for Johnson & Johnson as Vice President of International Government Affairs. I was spending a lot of time in Asia, including Taiwan and Latin America and other places around the world. And I was working on cancer, diabetes, HIV, infant and maternal health issues, the full range of physical health, working on hepatitis as well. I thought that we could do something as a healthcare company for mental health. And I naively thought it would not be that difficult. But when I talked to our neuroscience group, I started to learn that mental health is the challenge of our generation. I learned that the World Economic Forum did a forecast of diseases, and they estimated that mental illness will account for more than half of the economic burden of all chronic illnesses. And that's more than the combination of cancer, diabetes, and chronic respiratory diseases like asthma and COPD. So when I read that, I had a hard time believing it. I mean, how can it be that mental illness, which I thought was something that only affected my family, how could it be that big of an economic burden? How could it be half of all chronic illness economic burden? Well, the first thing is it's very common. 1 out of 4 people will have a diagnosable mental health condition at some point in their lives. Imagine if 1 out of 4 people had COVID, that would be a disaster. Well, 1 out of 4 people will have a diagnosable mental health condition, not just a mental health struggle, but something that's clinically diagnosable. The other thing is that mental illness is the only chronic disease of the young. Half of all mental illness begins before the age of 14, and another 25%, so 75% of all mental illness begins by the age of 24. And coincidentally, my daughter's mental illness started around the age of 14, and she was 24 when I got that phone call. Now, most people around the world, about 2/3 of people who have a diagnosable mental health condition, do not get care. Either they don't have access to it or they're too ashamed to ask for it. And the third of people who do ask for care often wait an average of 8 to 10 years. And that's what happened to our family. We didn't know what we were dealing with. We thought it was just a part of adolescence and growing up. And by the time we realized that it was a health condition, the disease, like any disease, if you let it grow, it will get deeper, more entrenched, more severe. And so by the time we got around to addressing it, it was very deep. So because mental illness is very common, because it starts in young people, because it goes untreated, the economic cost piles up over an entire lifetime. And it also starts to manifest in physical ailments. So if you have an untreated mental illness, you're not sleeping well, you're not taking care of yourself, you're not exercising, you're not staying socially connected, you're isolating, you're embarrassed. You might, in some countries, get caught up in the criminal justice system. You might be thrown in jail. And so, later in life, you're going to have higher incidence of cancer, of stroke, of diabetes, cardiovascular disease, and you're going to be more prone to contract other illnesses like hepatitis. So the economic cost is not just the cost to the healthcare system, because frankly, most countries don't spend enough on mental health. It's also the combination of these other costs to society, the cost of lost productivity. Mental illness is the leading cause of disability worldwide, so unemployment, and I mentioned criminal justice and other societal costs. And now this dynamic, this trend, this cost is actually increasing because most of the economy is moving towards a knowledge-based economy. When I was a child growing up in Detroit, Michigan, where we have our big auto companies, Ford, General Motors, and Chrysler in the United States, you could get a very good paying job in the factory, performing basically repetitive physical tasks. But those jobs are all automated now. And so almost any job you have in the modern economy, you need to have enough cognitive function, enough mental capability to collaborate with other people and to innovate either on your own or with the team. And so that's making mental health even more important than it was 10 or 20 or 50 years ago. And so the economic cost is going up higher and higher. And so we're starting to see this reflected in our news headlines. In my country, for example, average life expectancy has been going down for the last 6 years. Most recently because of COVID, but even before that, it was going down because of untreated mental health issues. So rising suicide rates, rising drug use and overdose, alcohol use and overdose. That was reducing American life expectancy. And the last time that happened was 100 years ago. So we had 100 years of increasing life expectancy until this mental health crisis started coming into the fore. And 100 years ago, that was World War I and the 1918 flu, the so-called Spanish flu. So that's what was happening even before the pandemic. And as I say, the pandemic has worsened shortened our life expectancy. And it also has exacerbated the mental health crisis. Now we're seeing more and more people having diagnosable conditions. Our mental health hospitals and treatment centers in the United States are overflowing with children, with adults, people of all ages. And then, so that's my country. But if you look globally, and you can, think about your own countries and find your own statistics. But the one that really affected me was the fact that in recent years, worldwide, the leading cause of death for teenage girls, ages 15 to 19, has no longer been childbirth, which it has been for centuries as far as I know. But in a couple of recent years, the leading cause of death has been suicide. And there are a lot of reasons for that, having to do with gender discrimination and other types of things, violence. But I don't have time to really delve into that during this talk. But those girls, I felt like they were calling out to me, and I felt we need to do something about that. So we, as a company, I, as a leader, decided to try to work with people around the globe to transform mental health care. And we focused on 3 areas. One is the stigma, the shame. And there we helped pull together all the advocacy groups around the world into a new movement called United for Global Mental Health. And you can look that up online. We also wanted to advance the science because there has not been enough investment. So we're working with the World Bank and the World Health Organization and UNICEF, because as I say, this is often a young person's illness, and Wellcome Trust and other groups to try to build a global fund for mental health, like the one for HIV, AIDS, TB, and malaria. And then finally, we're trying to change the system so that care is not so hard to find, that we try to address these illnesses early before they deepen and get entrenched. And we also try to bring more scientific rigor to the field. A lot of what passes for mental health care is not evidence-based or outcome-based. And we need to change that. We need to hold mental health providers to the same standards of effectiveness and safety as other areas of medicine and other areas of care and support. But one of the things that we discovered was that people who have chronic illnesses, sometimes those chronic illnesses are a result of untreated mental illness, but people who have a chronic illness like hepatitis or COPD or diabetes are at twice the risk for mental health challenges, mainly because you're under a lot of stress, you're isolating, you're ashamed or you're embarrassed by your condition, or you're afraid of discrimination if you become too public about it. You're afraid of losing your job. And so you have this chronic stress, and that leads to increased exposure or incidence of mental illness. At the same time that we in the general public face this, or we with hepatitis face these challenges, our healthcare providers also face this increased risk. They're under a lot of pressure because of COVID, because of all the healthcare challenges, including the mental health crisis. Now, it's not up to our community here today to solve the mental health crisis, but I think it's important to recognize that we're part of a larger movement on mental health. And so we can take care of ourselves and each other in a way that contributes to transforming mental health care worldwide. We've come a long way on mental health in the last couple of years. We have a long way to go. We're talking about massive culture change, ending the stigma, making sure that people are included, and also massive system change, making sure there's more research and changing making sure that people have access to evidence-based care. But there are some small things we can all do to advance mental health in our fields. We can, first of all, start to acknowledge that mental health is very common. It's really part of the human condition. Everybody during COVID recognized that they're under mental stress and subject to these kind of conditions. We can start to take meals or casseroles, we call them in my country, to each other's homes when somebody is sick with mental health struggles, just like we do when they have cancer or they have flu or COVID. We can start to talk to our children about this. So this is a young person's illness. Teach them as much about their mental health as we now teach them about their dental health. And we can really begin to recognize that mental struggles are not about weakness. They're really not about character at all. They're about often chemistry and always about community support. So I'm delighted to talk to you today, and I look forward to the panel later. And I want to ask all of us to work together so that we can answer the call of history on mental health. Thank you very much.
Thank you, Craig. We'll come back to you with the question and answer session. So your talk was a nice segue into the next talk, which is why do patients with hepatitis have higher rates of depression and anxiety? And this is going to be given by Sherry Cohen, who is the president of the Hepatitis B Foundation. She wears a number of other hats. I don't know whether I have time to mention all of those, but let's get on with her presentation. So Sherry, are you there or? Oh, she's got a pre.
Good morning. My name is Sherry Cohen. I am the president of the Hepatitis B Foundation. And I'm going to talk a little bit about the mental health impact of living with hepatitis B today. I want to just first point out, and something we all know, but we don't talk about enough, how important it is to understand the holistic quality of life impact of living with hepatitis B. Over the past number of years, Hepatitis B Foundation and partners around the world have been working to try and better understand what the physical, psychological, professional, and social impacts are of living with hepatitis B. We have been working with people living with hepatitis B in many, many countries around the world to document their lived experiences and to figure out what they want, what they need, and what their challenges are. And we're hoping that in doing this, we can bring better programming and improve the quality of life of people living with hepatitis B. This gives a little overview of how we've been collecting our data. We hosted with the FDA an externally led patient-focused drug development meeting in 2020 with about 650 participants. We also conducted an online survey that same year with about 1,700 participants. We have been doing in-depth interviews for the last number of years, as well as data mining of over 10,000 email consults that we have been getting from around the world. And what we are finding is that there is a significant quality of life impact of living with hepatitis B, that it's not just physical and it's not just clinical outcomes, and that the impact of living with hepatitis B is complex, that the physical, emotional, and social impacts overlap with each other. None of this happens in isolation, and you have to think about that as you are documenting the impact and as you're thinking about how you can address it. In terms of physical impact, what we learned from all the data we've been collecting is that even though we talk about hepatitis B as though it's a silent infection, it really isn't a silent infection, and that in fact a lot of people do have physical symptoms, even in the absence of cirrhosis, fibrosis, or liver cancer. The two main things that people talk about in terms of physical impact is chronic fatigue and chronic pain, things like joint, muscle pain, and body aches. And both the pain and the fatigue have an impact on people's lives, especially in terms of productivity, ability to hold a job and to do certain professions, and the ability to take care of family and managing pain. And that these physical symptoms do have an emotional and mental impact, as we're going to see in the next few slides. From an emotional perspective, what we saw most pervasively and most commonly were anxiety, fear, and stress. And two major things here. We have anxiety and fear about the future, fear about progression to liver disease, especially liver cancer and cirrhosis. So people are afraid of what hepatitis B is going to do to them long term, and fear of transmitting to others. People are afraid that they are going to transmit the virus, especially to loved ones. And so we have to do something about this fear. We have to figure out a way to address it. But there are other issues like the burden of taking a daily pill, which kind of feeds into those fears as a daily reminder that they are living with a chronic infection. And also fear of being able to afford treatment. And this is, we found across the board among people in many countries, not being able to afford treatment now, or worried that people aren't going to be able to afford their treatment into the future. We also see that between the physical and emotional impact, people are self-isolating with hepatitis B, that they're limiting social interactions for two reasons. One is because they're tired and they're afraid and they don't necessarily want to have to disclose their hepatitis B, but also because they're afraid of stigma and discrimination that they will face both among their family, among their cohort and colleagues at school and at work, and among friends and coworkers. And so they're feeling self-isolated, but also feeling isolation from others when other people know about their infection. We are seeing pervasive harassment and discrimination among people living with hepatitis B, people who are losing their jobs or being prohibited from certain jobs, being prohibited from military service, kids not being able to go to school, being prohibited from immigration. So we know that discrimination plays a big impact in terms of the social, emotional, and mental impact of living with hepatitis B. People also feel stigma. And I just want to, point out that stigma and discrimination are two different things that are interrelated. And that stigma is also pervasive and comes quite a lot from lack of awareness and lack of knowledge. And what we need to do is figure out how to counter some of the misinformation that is leading to the stigma. Also, pervasive shame, people feeling like they're at fault, especially if they've transmitted to a loved one, or their fear that they might transmit to a loved one. And across the board, people wanting more support and more ways of engaging with other people who have hepatitis B as a way to share their fears and realize that they're not alone. To switch a little bit and focus on discrimination, we did work with partners to conduct a qualitative study a couple of years ago for people around the world to document their experiences with discrimination and talk about how they were how the discrimination experiences are impacting their mental health. And we found that there is a negative mental health impact of discrimination. And this is just a couple of the qualitative thoughts and feedback that we got from folks. And you can see that, there is this kind of shows you the social impact and what it does. So people are not going out, people don't want to get tested and don't want to go for treatment because of the fear of discrimination and what they might face. It's even causing things like depression and thoughts of suicide or attempted suicide. And so I think things like loneliness, fear, isolation, depression, anxiety, these are all things that are associated with living with hepatitis B, potentially associated with discrimination, but not always. And also things that we don't really talk about enough when we talk about management and healthy lifestyle for people who have hepatitis B. This just shows the cycle of discrimination. And I really like the arrows here because I do want to point out that it is a cycle, that this is a very complex situation and involving many socio-cultural factors at the individual level, at the structural level, that then lead to emotional and mental health outcomes that then kind of feed back into the socio-cultural factors. And so what we do see is this cycle happening over and over again. So the major takeaways here are that there is significant physical, social, and emotional impact for people who live with hepatitis B, and that this impact does appear to reduce quality of life and does appear to affect mental health as well. Living with chronic hepatitis B impacts family relationships, social relationships, as well as professional jobs, education, and careers. And we really need to do something about this. So now that we have been documenting these experiences, the question becomes, what do we do with what we learn? So first off, I want to advocate for including quality of life indicators into the management, the clinical management of hepatitis B. It's not only about reducing DNA or reducing surface antigen or normalizing ALT. We need to be more focused on the quality of life and the mental and emotional health of people living with hepatitis B. We need to create supportive programs for people living with hepatitis B, things like support groups like the Hep B community, which we're very happy to be part of, but we need more of that. I mean, there's 300 million people living with hepatitis B. How can we find support for them and ways for them to engage with each other? We need to end discrimination. And so, that takes a lot, but I think that we can do it with a policy change. And I think that ending discrimination would impact quality of life and mental health for people living with Hep B in many ways. If nothing else, it will make people more likely and willing to get tested and into care because they're not going to fear discrimination. And we also need to address stigma. I think normalizing discussion about hepatitis B and doing what we can to, from a very culturally sensitive way, overcoming misinformation and trying to get correct information out there about hepatitis B will do quite a lot to help address stigma. And that is it for me. Thank you very much. And I look forward to questions.
Thank you, Chari. So we'll move straight to our next speaker, who is Thomas Tu. We heard a little bit from him earlier, and he's going to speak to us now as the founder and director of hepbcommunity.org. Similarly to Chari, he wears more hats than I have time to list, but he also is the president of the Australian Centre for Hepatitis Virology and adjunct associate professor at Westmead Institute for Medical Research at the University of Sydney.
So thank you to the organisers for inviting me to give a talk. These are my declarations and disclosures. I just want to emphasise that these are really my personal impressions. So I was diagnosed with hepatitis B when I was about 14. And the first response after that diagnosis was this overwhelming panic and emotional overload. And really, I wasn't able to absorb all the information that was given to me by my doctor. After a few days, I sort of recovered from that initial diagnosis, and I felt alone. I felt really that I had no one to discuss this with. And as a result, because it was so difficult to get information to really understand what was happening to me, it was easier just to ignore it, because really I was young, I was healthy, or feeling healthy, had no symptoms, no one was chasing up about monitoring, and really that might have been the last of it until advanced liver disease. But in the end, I got a PhD in hepatitis B research and now lead my own group. But because of what could have been, I wanted to prevent others from going down that road. So I started hepbcommunity.org to really chat with the broader affected community. So this is a community forum to get trustworthy information. The community bit is really key here. We're getting the affected community together to be able to talk to each other. And this is one of the main focuses of the forum, just opening that conversation. But of course, that trustworthy information is also important. So we have experts on the forum to be able to provide that clinical or scientific information, and those sources of information are marked accordingly, so it can be trustworthy. This is really a win-win resource for health professionals or experts in the field. You can learn from other specialists, learn from the affected community themselves, so they have concerns, highlight misinformation or other issues that may stop access to care, that may affect your day-to-day work. And clinicians in particular can refer patients to support outside of these 30-minute consults, 15-minute consults every 6 months. So it's a way to make sure people are still engaged with their condition. It also benefits the affected community. So they have access to expert advice. They can socialize and get information from others in the comfort of their own home, in a sort of anonymous way, so they can avoid the stigma associated with Hep B. And they, just knowing that others share the same experiences is actually quite relieving. And because this is a sort of safe environment, people do share their experiences and open up about the impacts of hepatitis B, which I'll discuss today, particularly those mental impacts, of which there are many, and I'll be discussing a few in the next few slides. So when people first go onto the forum, a lot of the time they say that it's the first time they've been able to really open up and talk about hepatitis B to anyone. And this really shows that people are really isolated when they first get their diagnosis. And this could be decades after that initial diagnosis. So they've been feeling that isolation for decades. People are also quite afraid when they're first diagnosed. A lot of the times, we as scientists or experts really emphasize the physical and health impacts of hepatitis B. So many people die of hepatitis B, the liver cancer and liver cirrhosis. And this is really the first thing that people see when they Google Hep B. And so they see it as, in many cases, like a death sentence, and that life is over. They lose hope for the future and what they have planned for their lives. So, and this really isn't the case. It can be a chronic condition that is managed. And so this is where the forum really is a solution in itself. Just seeing and talking to others living with Hep B and seeing that people can live normal lives is really uplifting and helps a lot of these particular impacts. There's a sense of frustration as well when people first get to the forum. There's a lack of accessible information, and I emphasize the word accessible, that it's in language they can understand, and it's explained to them and answers the questions about the issues that are they're facing, rather than some abstract, nebulous liver disease progression or changes in lab values sort of thing. There's also frustration that there's a perceived lack of progress on a cure. I guess we as scientists have been emphasizing that, there may be a cure in the next 5 years, next 10 years. And when that doesn't come up, people lose hope and that fuels that frustration. And that lack of straight answers to simple questions like what's the best food to eat sounds like a simple question, but it's actually quite difficult to answer. And there may not be one indeed. So the potential solution here, and again, this is colored by me starting Hep B community, but I think one of the solutions is accessible, again, emphasized, and personalized information. And a lot of that can be done through peer education, so that is accessible, and answering people's questions directly, so it's personalized. Gary has already talked about the anxiety associated with Hep B, and I'll just go through it quickly. There's that reduced lifespan and suffering that I just mentioned, but also there's the converse of keeping healthy. People become really thinking about everything that goes into their body. Everything is potentially bad for them or potentially good for them. And there's again that worry about how do I fix this disease that's in my body, and how do I get back to normal? There's also the life change associated with the lifetime of monitoring and potentially meds. There's not only the financial strain, but also the time taken, that the continual access that you'll need to plan in, and the effort to go to these consults twice every year for the rest of your life. And this really has impacts on life plans, such as where I want to migrate to. Does it affect what kind of work I do, how I study, what hobbies I do, health insurance, all of that sort of thing is impacted by Hep B and contributes to the anxiety. What also is sort of hard to take in some instances is bearing that responsibility of limiting transmission. So we tell people not to share razors, make sure everyone around you is vaccinated. But as a person, as a single person, it's really difficult to get others to for example, be vaccinated. That's even with the full force of governments and health departments, we have trouble vaccinating everyone against COVID. You can see how much pressure that puts on a single person. There's a hypersensitivity to body changes. So any these are just examples from the forum, but any changes in your physical body could be something that marks the progression of liver disease. People don't know and really ask a lot of questions about this, whether what they're experiencing now is caused by Hep B, or indeed side effects for their medications. And there's also test anxiety, the anticipation, waiting in the for a consult in the doctor's waiting room for the results to come back, for another consult to interpret those results. It's a lot of waiting and like having a sword over your head. Those who are impatient can look at Dr. Google, but again, that a whole lot of information comes through of things that it could be when lab results are abnormal, for example. And there's also incidental findings that, you know, there are a large fraction of people, healthy people, who have liver cysts or adenomas or fatty liver and live without knowing. But it's people with Hep B who are getting constantly monitored. This will come up and again be a worry to them. Hep B can also strain relationships a lot. So if a partner is suddenly becomes diagnosed with Hep B, there's a lot of feelings that come in, and infidelity in particular becomes a big concern, or perceived infidelity becomes a big concern. There's also the guilt of potentially exposing others, whether that be a partner or children. Disclosure, particularly in casual or early in the relationship, there's awkwardness associated with that. There's also a whole bunch of effort in explaining what Hep B means, particularly if you don't have the information there to be able to explain those things, or the knowledge there. So there's this anxiety of being trapped between either hiding your status or the having the risk of losing someone. And indeed, some people have had bad experiences in disclosure and end up with trust issues because others have left them. This all becomes very hard for some people, and they even withdraw completely from either from pursuing relationships or expecting any or expecting to get married or something. So this can be really hard on someone. So in conclusion, Hep B is more than just a medical issue. These mental impacts affect those who are, you know, asymptomatic in biomedical sort of terms. And these mental impacts have historically been rather overlooked. What's important to note is with broader diagnosis, so universal screening, for example, or pushing of more diagnosis, these mental impacts are likely to increase. So we really need resourced measures to be able to address these issues now. I may be biased, but I think these need to be peer run so that people with Hep B are able to trust those providing that information. It should also be peer-led because we need an understanding of those issues that are affecting the community and make sure that they're being addressed. So I'd like to thank everyone that has contributed to hepbcommunity.org, particularly the affected community. And thank you again for inviting me to speak.
Thank you, Thomas. We'll come back to you in the question and answer session if there is time, I guess. Right on to the next speaker, who's Ajit Badoria. He is a young man from the All India Institute of Medical Sciences, Rishikesh, an associate professor in preventive hepatology, which really is a topic, is a title that I like very much. It's interesting, it's new. He's contributed quite a bit to various GDGs, WHO GDGs on topics related to viral hepatitis. So he's going to talk about family screening, diagnosis and about hepatitis B infection. Ajit.
Thank you so much, Sayed, for the kind introduction. And a very good morning to all of you. I know we are running late. I'll try to be fast so that we can bind up the session in time. I have to take care of mental health of everyone. So important, very important topic. And I'm really thankful to CEVHAP, WHO, and APASL for giving me the opportunity to speak on my work. So when we talk about the mental health of patients, it's important to understand the mental health of family also, and we are taking care of the mental health of caregivers and family for all chronic diseases, cancers, and end-of-life care. But for hepatitis B, one thing is more important, that we should also screen them for hepatitis B markers. So I'm not going into this detail. We all know that hepatitis B has a huge burden, economical burden, and we know that we have to take care of this disease, and it's possible only if we can increase testing so that we can find those who have hepatitis B and then we can treat them. So rationale is to pick up the people who are hepatitis B infected, who are living in the community among the people spreading the infection. So out of the other most important strategies which we have, like high risk group screening, micro elimination, small target groups, or targeting small areas, one strategy that could be important is family screening. Why? Because we know that vertical transmission and horizontal transmission both are very common in hepatitis B. So if a person is infected, like we have seen in the story of Jackie, that when the brother was infected, then he got tested, he got positive, and then the wife was also positive. So this is a very good opportunity. We can utilize this opportunistic screening public health approach whenever we see a patient in our clinic, that at least other people in the community, in the family who are in close contacts, they should be screened. And close contacts, I mean first degree relatives, parents, siblings, offsprings, plus a spouse. So at AIIMS Rishikesh, we are running a preventive hepatology clinic along with the liver clinic. So whenever a patient comes, he goes to the hepatologist, gastroenterologist, get the treatment required for himself, and then he is referred to me. At that time, I with my team, we try to counsel, educate, and convince these attendants that everybody in the family need to be screened for few viral markers. So these viral markers are hepatitis B surface antigen for active infection, anti-HBC for any remote infection, and anti-HBS whether the person is immune or not or need vaccination. So it's a multi-level, or I'll say it's a 3-tier counseling and education strategy, because it's very difficult in India when you are seeing 3,000 patients in OPD, people, they're coming in the morning at 8 o'clock, and then they are getting chance to see the patient, see the doctor after 3-4 hours of long waiting period. And at that time, you're saying that family members also need to be screened. You also go and get tested for these particular tests. So they are that time, they are in the mood. They say, please, doctor, see the patient, see my family member who is currently suffering, and give us the advice regarding that particular patients. And whenever we'll get chance, we'll get ourselves tested. So even after offering these tests free, they are not, getting convinced, and they are not going for tests. So we try that at least clinicians should say something about the importance of family screening. Then I, as a public health specialist, try to make them understand about the need of family screening. And then a nurse who's in the section where they get these tests done, she also tries to convince them. So this is the IC pamphlet. We also use it in the local language so that we can make them, I know it's very long, huge, I think I have to reduce it. So it should be very simple messages for the family member, that why it is important for them to go and get screened for this deadly disease. So outcome of my work. So we have around, I've enrolled 93 index cases. I'm not going into the detail of index cases because that is not important. Of these 93 cases, 463 family members were there in their family, including first degree relatives plus spouse. We have tried to get all of them screened, 143 directly in the clinic when they are accompanying these patients, and 320 indirectly, they are at home. We tried to convince them to go and get themselves tested by any lab in your area. Or if you want your family members to get screened, tested free, you can bring them during your next visit. So we have screened around 221 contacts out of this 463. So around 47.7% of effectiveness or impact of this whole 3-tier screening, counseling, education, and screening process. Now the finding, you'll shocked by seeing that active infection was seen in 1 in every 4 family members. So out of 4 family members, 1 is having hepatitis B surface antigen positivity. That is around 24.2%. Past infection rate, if we see only, if we talk about only anti-HBC positivity, was seen in 1 in 3 family members. So sometimes some infection at some point of time in their life was there among 1 in 3 family members. And overall infection rate, when we talk about either HBsAg positivity or anti-HBC positivity, was 42.1%. Like 1 out of 2, they have either one of the marker positive in their blood samples. Out of those who are so this also gives us an opportunity to get them vaccinated. Now they know that their family members, they are infected with one or other marker. So those who are not, those who are clear, those who are susceptible, they are then motivated to get vaccinated in the institute. And we have around vaccinated 61 individuals. And we are either vaccinated completely or they are initiated by first or second dose. This is also a very important finding. If we do some statistical analysis, we have seen the odds ratio was 3.2 for the positivity of a mother in the among all the family members, which hints or which directs towards mother to child transmission. So there is the chances of the patients which we are seeing, they are mainly because of mother to child transmission. So if a person is positive, the chances of mother being positive is 3.2 times higher as compared to other family members. Right. So this also give emphasis on prevention of mother to child transmission by hepatitis B birth dose, screening pregnant females, and giving hepatitis B immunoglobulins if the mother is positive. So small, simple 2 take-home messages that family screening is a high yield additional strategy. If the prevalence in India for hepatitis B infection is 2 to 7% or is around 4%, that means if we'll screen 100, we'll get 4 hepatitis B patients. But if you screen 100 family members, you'll get around 5 to 8 times higher yield. That means around 30 to 40% people there, 30 to 40 persons, they can be enrolled in the healthcare. They can be linked to care. So it's a high yield additional strategy for testing, and case detection rate is 5 to 8 times higher as compared to general population. That's all. Thank you so much.
Great, thank you so much. That is a fantastic model, not just for testing and prevention, but also for education and doing a lot to address the stigma and discrimination and the fear that people feel about disclosing status to loved ones. So we do have some time for questions. So I'll open it up to the floor, and also for those online, you can submit questions through the chat and I should be able to bring them up here. But just to get started, I have a question for the panel. So, we know that, well, we've heard a lot that, mental health is a huge problem, but it's not often spoken about. And so what, in your opinions, can we do to change this? And any takers who want to answer first? This is to all panelists. All right, I'm gonna, Ajit, you're next to me, so.
So it's a very important point raised by Jessica, that mental health is something which is very important. Even mentioned by Cherry, that if we are only focusing on the clinical aspects, bioclinical aspects, symptomatic aspects of the patient, treating only physical health will not help. So we have to take care of mental health and social health of all the patients. There should be a mechanism to find out or to see or to check or to assess this mental health and social health of the person. There should be someone who is taking care of it, documenting it, and then trying to solve that issue. So this is something which is missed out, not only for hepatitis B, I'll say for most of the diseases. We can't get our people happy, healthier by only taking care of their physical health. So it's really important.
Thank you, Chari.
Can you not hear me?
We can hear you now.
Okay, perfect. Okay, thank you, Jess. I think there's a role for everyone to play. Everyone in this room, virtually or in person, there's something that everyone can do. I think from a clinical standpoint and research, from a clinical standpoint, we can start thinking about how to incorporate mental health into the medical management of hepatitis B. I think from a research standpoint, we can think about documenting even greater what some of the impacts are and what we can learn from other chronic conditions. We're not, people with hepatitis B, we can learn from other chronic conditions where people are also stigmatized or isolated or afraid of progression to others, progression to serious illness later in life. I think there's a lot we can learn, and I think we should start doing that. But I really like Thomas's idea. So I think we need to measure it. We need to pay attention to it. We need to start talking about it. But I love Thomas's thought that, what kind of programs, what can we develop? What can we support that would be peer-led? I think it's really important to get the community of people living with hepatitis B activated around this issue. They're the experts, and I think they have a lot. Folks who have hepatitis B can help each other in a way, if only we could support and guide them in a meaningful way.
Great, thanks, Chari. And Thomas, I see your hand is up.
Thanks, Chari. Great points that you raised, particularly the one around me, but no, I want to extend on that and really go back to when I decided to publicly say that I have Hep B, and it was because other people had publicly said that they have Hep B, this in particular being Sue Wang and Joan Block, publicizing their status. And I think the role of champions and public figures who are out there talking about the issue and saying, okay, it actually exists and you can live a normal life. It's part of the human condition, as Craig had mentioned. And it's something that is prevalent, and you're not alone when you're affected by these conditions. That, I think, is a major approach that we can all take as a community.
Great, thank you. And I completely agree. We definitely need more voices speaking out. Craig, I'd love to get your take on this as someone that's working outside the hepatitis space, how we can better make these links between the hepatitis and mental health and shine a light on the impact that hepatitis is having on people's mental health.
Yeah, thank you. And there's a lot of commonality. I think we're in many ways fighting the same fight. So I think the more we talk about either mental health or hepatitis or other chronic conditions, the more we tell our stories. Storytelling is a big part of our mental health movement now. We obviously want to hear from people with lived experience and try to tailor solutions that are accessible and appropriate, but we're also trying to build a movement and change minds and mindsets about mental health. So I think Thomas and Chari, the focus on not only storytelling, but peer support in the absence of adequately trained providers and evidence-based practices is an important place to start. And then I think there are some self-help things we can do to get ourselves into a place where we're doing well and where we feel supported or resilient. And I'm not a clinician, so I'll leave that sort of thing to Chari and the others. But in my own experience, there are a couple of things that are really important, and I've seen this clinically around the world. Is very simple things like making sure we get enough sleep, making sure we are exercising and eating well, making sure we're staying socially connected. If you do those four things, oftentimes you can put yourself in a position to better address your physical conditions, but also manage your mental conditions.
Great, thank you. And something that you touched on right at the beginning is sort of how parallel and similar the two issues we're talking about is. So how can we as the hepatitis community connect to the major global movement that you're involved in with mental health?
Well, I think in every country you're going to find more and more voices on the mental health side. Globally, United for Global Mental Health, you can Google that and it's very easy to join that movement. The group is trying to connect everybody globally, provide a sort of a global action plan that can be implemented either at the United Nations, the World Health Organization, or locally in your local community, your village, your city, your country, and so that we're all sort of pushing in the same direction. One example of that is that in spite of the fact that mental health is the greatest economic burden in healthcare, most countries spend disproportionately little on mental health. So one of our global asks is that not that countries spend more on healthcare, but that they take more of their existing health budget and devote more of that to mental health. And you might be shocked at how little is spent on mental health. In many countries, it's less than 1% of the overall healthcare budget. But because of that connection between physical and mental health, if you spend a little bit more on mental health, you avoid longer term chronic physical ailments. So that it's a good investment. It's a smart investment. And the same thing is true of one of the biggest components of the global movement is the workplace mental health movement. Because it's the leading cause of disability, because employers increasingly rely on the brain power of their workforce, and also because of the fallout from COVID and the burnout and things we're seeing across all sectors of the economy. Employers, whether they're government employers or private sector employers or nonprofit employers, are really starting to be aware of the cost of not addressing mental health. And so that organizing in your workplace around mental health, and I would think also around, because the efforts are so parallel, the hepatitis movement, I think is another good place to start.
Okay, thank you very much for the whole panel. I think this has been a very informative and interesting and an important session. I'm a clinician who diagnoses patients with hepatitis B and treats patients with hepatitis B. And I can tell you it is extremely discomforting for me as well to announce or pronounce that diagnosis. And what I do is just what I can, what comes to mind in terms of reassuring them or giving them some sort of support. But from this session, my takeaway is that perhaps we need to do this on a much more formalized level, certainly for the newly diagnosed patients. So I think it'll be very nice if the organizations that are in this room, CEVHAP, WHA, and so on, can agree on a list of things to do, which is generic, which is translatable to many countries across the globe, particularly Asia Pacific. For example, linking them to peer groups, for example, getting a formal psychological assessment done, and so on. I would love to see something like that happen because, trust me, it's not comfortable for the treating or the diagnosing physician to announce this diagnosis as well. So with that, I hope that we will have some further progress in this area when we next meet. Thank you very much for a very interesting session, and all the best to you.
So we have a slight change to the schedule, and we're going to invite the chairs of our next session, Carrie, James, and Bob Gish, up, and we will play the story of Ho Ching Chuan at the end of that session.
Of the bias. Yeah. Good morning, everyone. Very happy about the attendance at this wonderful meeting this morning, the format, and all the information today, as well as the online attendance. I am Robert Gish. I wear a couple of different hats, but I'm a founding member of CEVHAP, and I'm also the medical director of the Hepatitis B Foundation. I think I'll give the microphone to Carrie just for a moment. Everybody knows him, but it'd be nice to have a formal introduction online.
Hi again, I'm Kerry James. I'm Chief Executive of the World Hepatitis Alliance, and we're a network of community-based and patient-led organizations in more than 100 countries around the world. So great to be with you today.
Our first speaker is going to be Dr. Mohammed Rasas from Kuala Lumpur, a consultant hepatologist and a global leader in hepatology. She'll be talking about liver cancer diagnosis, what this means for patients according to where they live, comparing patient access to testing. And then we'll be moving on to various countries with Jess Howell and Dr. Hung Dao. So a few more minutes to follow this first presentation. Ross, welcome.
Thank you very much, Doc. So, if you just put this on PowerPoint, go to the next slide, it will be on recording. Can the organizers go to the next slide, please?
HCC is now the third leading cause of cancer death worldwide. Liver cancer is the sixth commonest cause of cancer in Malaysia, but it's ranked as the fourth common cause of cancer-related deaths. The number of new HCC cases and deaths per year are nearly equal, underscoring the poor prognosis of HCC. The underlying causes of liver cancer at the global level are shown on this slide. Now, hepatitis B accounted for the most number of liver cancer at 46%, followed by hepatitis C in 29%, alcohol in 17%, and 17% others, which include other causes of hepatitis. These are signs of modern times, with increasing number of individuals, both adult and children, with expanding waist circumference. So fatty liver is now rapidly becoming an even more important risk factor for development of liver cancer. These three studies clearly show the changing pattern in the underlying cause of liver cancer. Hepatitis B remains the commonest cause of cirrhosis and HCC in Malaysia. But the latest study on the right highlights that MAFLD will probably soon overtake hepatitis B as the commonest cause of HCC. The changing etiology of chronic liver disease associated with HCC is very much a global phenomenon. Now, studies from the US and this English study showed rising prevalence of NAFLD-induced HCC over the years. As NAFLD and chronic hepatitis B are common liver disease, there are a significant proportion of chronic hepatitis B patients with concurrent fatty liver. Now, this meta-analysis showed an overall prevalence of 34.4% of MAFLD in chronic hepatitis B patients. Alarmingly, nearly 50% of our chronic hepatitis B patients have concurrent fatty liver, and advanced liver fibrosis was found in 21% of the patients. Now, the independent risk factors associated with advanced liver fibrosis includes the diabetes mellitus, and advanced liver fibrosis was an independent predictor of composite events such as cardiovascular and malignancy, liver-related complications, as well as overall mortality. This large study showed presence of methyl D in 13% of the chronic hepatitis B patients. So among those with methyl D, diabetes could identify patients at high risk of HCC and mortality. This study showed that majority of patients were symptomatic at the time of first presentation, with 50% having advanced stage HCC. HCC surveillance is very much underused in Malaysia, similar to the meta-analysis which showed a poor surveillance estimates of 26%. Now, noteworthy, there were higher surveillance in GI hepatology clinics versus primary care clinics or population-based cohorts, and lower surveillance in patients with fatty liver disease or NASH. There is consensus amongst major international guidelines to recommend HCC surveillance in high-risk individuals. However, a crucial step before HCC surveillance can be utilized is the implementation of screening programs to identify individuals at high risk of HCC. Without doubt, identifying and treating the underlying liver disease early can prevent or at least reduce the HCC risk. Screening for HCC risk factors is an important step to optimize HCC prevention and early detection. Now, as fatty liver disease is now the commonest liver disease worldwide, I would like to share a methyl D screening program which integrates identification and surveillance for those at risk of HCC in a methyl D care continuum. As fatty liver disease is present in up to 70% of patients with type 2 diabetes, the inclusion of liver disease and FIB-4 assessment in the CPG on type 2 diabetes provides a wonderful opportunity to screen and stratify fatty liver disease using simple blood-based biomarkers and sound the alarm for those at risk of HCC. Now, FIB-4 consists of 4 parameters: age, ALT, AST, and platelet count, and a high cutoff value of more than 3.25 predicts those at risk of HCC. Note that other causes of liver disease will need to be excluded in patients with methyl D. Therefore, screening for other common HCC risk factors such as hepatitis B, hepatitis C, and alcohol excess can be integrated. Now, at the primary care sites, there needs to be differentiated care or triage strategy to determine specialist referral for those with advanced liver disease or cirrhosis for HCC surveillance and early detection of HCC. HCC surveillance has been proven to be associated with early-stage detection, particularly in patients with cirrhosis. Now, this recent meta-analysis showed that HCC surveillance was also associated with increased likelihood of curative treatment and overall survival. This is a proposed National Comprehensive Plan for HCC. A multidisciplinary approach is essential to provide evidence-based treatment options for HCC. Therefore, a key action plan is to enable access to MDT nationwide. HCC is a complex disease, therefore a multidisciplinary team is central to the management of this disease, and access to MDT discussions should be made available nationwide. To conclude, poor prognosis of HCC is related to late diagnosis and underutilization of HCC surveillance. Now, the changing pattern in the epidemiology of HCC is largely due to the rising prevalence of fatty liver-induced HCC. An important strategy to reduce HCC-related mortality is early detection of HCC risk factors and identifying at-risk population for HCC surveillance. Now, lastly, access to a multidisciplinary approach is key to defining the optimal evidence-based treatment options for HCC. With that, thank you.
Thank you so much. And we're now going to go to Australia and Dr. Jess Howell, who's a consultant gastroenterologist, principal research fellow at St. Vincent's Hospital in Melbourne, part of the Burnett Institute. So please, Jess, take it away or play her video. Thanks.
Thank you for the opportunity to speak today on liver cancer diagnosis, what this means for patients in Australia. And I'd like to begin by acknowledging the traditional custodians of the land upon which I'm speaking today, the Wurundjeri people, and pay my respects to elders past, present and emerging. These are my disclosures. Primary liver cancer is the 5th most common cancer worldwide, accounting for 7% of all cancers. And we know that it has an abysmal 5-year survival of only 18%. If we do nothing now, the WHO estimates that 1 million people will die of liver cancer by 2030. Now, if we look at the blue incidence graph shown on the left and the orange-red mortality graph shown on the right, you can see in our Asia-Pacific region, we have a high incidence and mortality, and Australia has moderate incidence and mortality to provide you context. Now, worldwide, hepatitis B and alcohol-related liver disease are the most common causes of HCC, but the prevalence of multiple liver diseases is increasing, with more than almost 3% of patients having more than one liver disease or liver disease cofactor, and this represents a major challenge for surveillance and management. In Australia, hepatitis C used to be the lead cause of HCC, but since the universal availability of DAAs, now alcohol and metabolic-associated fatty liver disease are far more common than hepatitis C-related HCC, showing the clear importance of prevention and public health strategies to reduce liver cancer. Now, in Australia, we're very fortunate that we have universal healthcare in our Medicare system, so patients in the public health system have very minimal out-of-pocket costs. However, we do have the challenge of remoteness and geography, and this is particularly inequitably experienced by Aboriginal and Torres Strait Islander First Nations people. And this is shown very clearly on this graph here. This graph of greatest prevalence of HCC shows the very high prevalence of HCC in the northern and central most remote parts of Australia. This is also where we have minimal access to healthcare, and it's areas where a very high proportion of Indigenous Australians live. In urban centres, we see a higher proportion of HCC in areas that are lower socioeconomic background and where there are a high proportion of migrants with hepatitis from hepatitis B endemic areas. Now, the challenges in HCC diagnosis are the same worldwide, and Australia is no different. There are low rates of diagnosis of cirrhosis, including repeat testing for cirrhosis when active liver disease is progressive, and low awareness of the survival benefits of HCC surveillance outside of the hepatology sphere. And in particular, this is the case for people with chronic hepatitis B without cirrhosis and people with cirrhosis who have hepatitis C who are then cleared with DAA therapy, and the lack of recognition of the need for ongoing surveillance. Low uptake of HCC surveillance due to multiple barriers is also a key factor. Now, if we consider the liver cancer roadmap, there's an intersection between the liver disease cascade of care and the HCC cascade of care. And in Australia, we do pretty well with diagnosis of chronic liver disease and even with treatment rates. But the key issue is that fibrosis risk is inadequately assessed, cirrhosis diagnosis is inadequate, and people are not referred in a timely way to a HCC surveillance program. And this is shown by our data showing that less than 40% of our HCC are diagnosed through surveillance and less than a third are diagnosed in early stage. Now, once patients enter our HCC cascade of care in Australia, they tend to receive timely therapy. So if we go through the HCC diagnosis and management pathway in Australia, who receives HCC surveillance? Well, our guidelines are in accordance with all international guidelines, but we have an additional group with Indigenous and Torres Strait Islander peoples over the age of 50 also requiring surveillance. Identifying those who need HCC surveillance occurs through multiple different services. For diagnosis of chronic liver disease, this generally occurs in primary care with GPs and sometimes through specialist outreach services such as nurse-led models targeted to people who inject drugs, for example. Fibrosis risk would then be assessed in primary care by a GP, looking at, for example, an UPRI or FIB4 calculation from routine blood tests. Then, if required, they would be referred usually to a tertiary centre for further investigation of cirrhosis, such as with a FibroScan, or again, occasionally we have some specialty outreach FibroScan services in regional areas and specialist services such as for hepatitis. HCC surveillance programs would then commence, and usually this is a partnership between a primary care physician and specialist. Most surveillance still occurs in Australia in tertiary settings, but it can occur in community radiology in partnership with GPs. Now, how we identify cirrhosis in Australia, we have various techniques available to us, but importantly, all the key ways that we diagnose cirrhosis in Australia actually are not covered for funding by Medicare. So what we do is, for example, with FibroScan, is this is incorporated into a standard clinical visit for a patient, so they have no out-of-pocket cost, but this means that the time for a physician, for example, may not be reimbursed. Availability is limited to hospitals and special outreach services, and it can be quite limited in some states with patchy rural coverage. Acoustic radiation force imaging with ultrasound is provided in some radiology centres around the country, but there's patchy coverage again, and again it's not covered by Medicare. So in some centres it may be free for patients, and in others they may have an out-of-pocket cost. Liver biopsy is covered by Medicare, but of course is limited in its use and only available in specialist tertiary centres. And finally, blood-based algorithms used internationally, such as ELF or HEPAScore as examples, are not widely available in all parts of Australia, though some states, such as Queensland and WA, are able to use these for patients. Now, if we consider the HCC cascade of care, we are very fortunate in Australia that all imaging for HCC diagnosis is reimbursed by Medicare, including MRI scans. But access to MRI for regional patients can be more challenging. All HCC cases are supposed to be referred to a tertiary centre for a hospital MDT or multidisciplinary meeting. And at this meeting, we would review, there'll be all specialists involved in the HCC cascade of care, from nurses to hepatologists, radiologists, surgeons, oncologists and palliative care physicians and radiation oncologists. And we would all get together and review these images and ensure that an optimum management plan is determined, and then book them for this plan of care, usually in a tertiary setting, and also sending further correspondence back to the referring medical team. We have specialist nurse support, hepatoma nurses in most of our tertiary settings, and they support patients through every step of the cascade of care. However, nurse time and resourcing is variable around the country, and this is proving a greater challenge with the increasing HCC incidence and management complexity that we are now seeing. HCC treatment in Australia, again, we have access to most therapies available internationally. We have less availability of some systemic therapies. For example, in Australia, we only have atezolizumab, bevacizumab, sorafenib, and lenvatinib available for patients. But these are cost covered through Medicare with no out-of-pocket, or very minimal out-of-pocket cost for patients. Specialist tertiary centres, usually in large urban areas or capital cities, are who provide our HCC treatment. So this is very challenging for people in remote and very remote areas who may have to travel hundreds of kilometres to get care. Systemic therapy is more widely available because we can use regional day infusion centres, for example. And so for some patients in remote areas, this is a more attractive option than radiological treatments, for example. Most treatments in Australia have no out-of-pocket cost, though some therapies are available privately, and CERT access in Australia is limited to transplant centres as being reimbursed. Again, however, we have poor access to treatments in regional and remote centres, and particularly that means inequities of care for Aboriginal and Torres Strait Islander peoples who reside mostly in these very remote parts of Australia. So how do we improve HCC surveillance and management equity in Australia? Well, we have some innovative models of cirrhosis and HCC care, particularly outreach, including through our Royal Flying Doctors Service, where we may send a whole multidisciplinary team up to remote areas to deliver care, for example, with portable ultrasound machines and FibroScan. Hub and spoke models of care using telehealth and providing support for primary care physicians to deliver care remotely can be provided by tertiary centres, and one-stop liver shops, for example, in our Indigenous communities, providing all steps from ultrasound and FibroScan, education and blood testing, for example, with specialists and nurse-led teams can be very effective. Importantly, having health information apps is critical for patients, and particularly that are culturally appropriate, and the development of these in Indigenous languages by some of the teams in Northern Territory have been incredibly effective. So in conclusion, geography and inequitable access are major challenges for HCC care in Australia, even though we have availability of universal health care that minimises out-of-pocket costs for our patients. Liver fibrosis assessment remains a major obstacle and prevents people achieving timely HCC surveillance referral. We need to upscale our current tools and innovations that have been shown in research to work well, and new technologies such as portable ultrasound machines may improve coverage in the future. And I'd like to thank you, and I'm happy to take any questions.
Thank you, Jess, for that excellent presentation. Please stick around for our panel discussion shortly. I now have the honor of introducing my sister, Hong Dao, from Vietnam, who I've known since she was a teenager, close friends with her father as well, and have watched her career advance to many new positions in Vietnam, including a faculty position at the University of Hanoi, and very involved with the Vietnam Association for Gastroenterology and also for the study of liver disease. She'll now give us a perspective on liver cancer diagnosis and what this means for patients in Vietnam. Hong, xin chào.
Dear ladies and gentlemen, it is my pleasure to present about the liver cancer diagnosis, what this means for the patients in Vietnam. So this is the agenda of my presentation. So regarding to HCC in Vietnam, I would like to introduce about the prevalence of viral hepatitis in Vietnam. According to different studies, the prevalence of HVV range from 8 to 19%, and as WHO reported last year, it was 8.1%, and for HCV, it was 1%. In 2020, Global Count reported that in Vietnam, the prevalence and mortality rate has the HCC as the first rank, and we had the overall rate 2.4 times higher than the world average. However, when we look back for 20 years, we found out that the rate of liver cancer has increased rapidly in recent years and becoming the leading cause of death for males. According to one retrospective medical record review studies on patients diagnosed with advanced HCC in the north of Vietnam, we found out that 8% of the patients came with a symptomatic or during the regular health check. Most of the patients came in the advanced stage, more than 80%. So it means that the screening and surveillance program in the northern of Vietnam was really lacking of data. So how about the south of Vietnam? The situation is similar. According to one study, it was on a very huge number of patients, more than 24,000 patients in 7 years in Ho Chi Minh City, and the authors found out that more than 80% of the patients were diagnosed in advanced disease. So when comparing the characteristic of liver cancer between Vietnam and Taiwan, we also reported that the Vietnamese patients were younger, with more advanced stage, with larger size of tumor, invasions, and metastasis. So how about the approach, strategies, and challenges in the real situation in Vietnam? This is the algorithm by our Ministry of Health in our guideline in 2020. So it was very similar to the guidelines in other countries in the world, that we use CT scanner, MRI, and alpha fetoprotein in our clinical practice. And in case that the patients have atypical findings, we will perform liver biopsy. We also have other tools. For example, the GALA score with alpha FP, AFP-L3 and PIPCA2, it also shows the data of higher accuracy in Vietnamese population, and it has been available in some big centers in Vietnam now. But the problem is the cost. It was around $80 in Vietnam, and it was still high comparing to the income of Vietnamese people. And it was not available in primary care levels and not familiar to the GP or infectious disease doctors. Another biomarkers that have been shown some promising data is M2B-PGI. This biomarker has been reported for liver cirrhosis diagnosis, but for liver cancer, there are limited data and only few centers have this biomarker. ctDNA is a novel tool. However, it was has a high cost and very limited data with few sample size study in Vietnam until now. So when coming back to the strategy how to prevent SCC in Vietnam, I would like to come back about the levels of prevention strategy. We will have 3 levels. The primary to have the patients avoid with the exposure factors. The secondary level is to prevent the progression to SCC in risk factor populations, and the tertiary is to prevent the recurrence in the patients post-treatment. So coming back to our real situations, the good thing is that in recent years, we have the HPV vaccination program for children. We have the HPV and HCV checking in all levels of primary care for pregnant women. And we have available tools to diagnose SCC, both imaging and biomarkers tool. However, we still have some huge challenges. The first one is that even SCC ranks the #1 in prevalence and mortality of malignant disease, we do not have the national program for SCC screening, especially for high-risk population. The second thing is that now the viral hepatitis patients are managed in multi-specialties, GI, hepatology, infectious disease, GP, family medicine, etc. But there is still the lacking of adequate monitoring for high-risk population. And the third point is that it is very similar for SCC patients. SCC patients are now managed in multi-specialties by GI doctor, by hepatologists, by oncologists, sometimes by radiologists, sometimes by the surgeons or transplant doctors. So there is the lack of the adequate strategy and follow-up to unify what is the best option for the patient. I would like to spend some time to talk about the quality of life and the barriers for the patients in Vietnam. So there are several studies showing that most of the patients have the low quality of life. And especially when they are in the advanced stage, the score of the quality of life decrease very significantly. And even that using different tools like CEVHAP or using EORTC C30, the results were very similar, with the quality of life score very low in ACC patients. There is also a study to evaluate the depression of Vietnamese cancer patients. In this study, also having the liver cancer patients, and it's shown that the prevalence of having depression in cancer patients in Vietnam is nearly 30%. And it relates to the age, the income, the education, and the cancer type. So how about the pandemic? What happened with the ACC patients and what are the lessons? So for the Vietnamese healthcare system, very similar to other limited resources settings, we have shortage of medical equipment, and we are always facing of the burden in how to manage other disease besides COVID-19. In such kind of period, in Vietnam, we found out that the impact of IT is very, very important. It is the connection to promote the consultation and to promote the awareness for the patients. And in that situation, the smartphone apps is becoming more and more popular for both the healthcare providers and for the patients. And in many hospitals, we are familiar with telehealth. This is a very effective tool to consult the difficult case, and it helps us a lot in the situation that the transferation is still restricted, and it also helps a lot in screening for the difficult cases. We also have performed a study, a survey on our doctors about how we found out the difficulties and the factors affecting to the viral hepatitis management in COVID-19 period. And we found out that most of the patients could not come to the hospital due to the two main reasons. The first one is because the restrictions in that time, and the second reason is because they are afraid of the pandemic. And in that case, it is unable for the patients to attend for the follow-up medical examination. So how the Vietnamese doctors deal with this situation, especially for the viral hepatitis and ACC patients? We promote the online and phone consultation activities to ensure that our patients still comply with the treatment, and we try to find out the complications that are occurring to our patients. We hope that it could minimize the impact of COVID-19 to the severity of the chronic disease. And the second point is that we extend the prescription duration. According to the government insurance, we only can prescribe the drugs for 1 month, but in that time, the Ministry of Health approved for us to extend the prescription as 2 or 3 months for stable patients. And it helps patients a lot. And the third activity is we try to foster the activities of the local healthcare units via telehealth. And after the pandemic, when summarizing the main results and asking about the opinions of the doctors, we found out that they really appreciate the role of mobile applications, online support, and hospital-like support to help the patients during that time. So I would like to conclude my presentation in several points. ACC is a burden in Vietnam due to the high prevalence of viral hepatitis, and the early stage diagnosis rate in our country is still low. The quality of life in our ACC patient is also very low, with the barriers in approaching diagnosis tool and financial limitation. And in COVID-19, we found out that we should promote more consultation online and the telehealth in all medical field, including ACC and viral hepatitis patients. Thank you for your attention.
Thank you so much. It was really great to see how 3 different countries, all the commonalities, but also the innovations in their approaches. That was fantastic. So now we're going to welcome back to the stage Dr. Saeed Hamid, who is currently the Kamruddin Mohammed Jassani Endowed Professor of Medicine and Director of the Clinical Trials Unit at Aga Khan University in Karachi, Pakistan, to speak about populations in resource-poor settings developments in Pakistan.
Thank you very much, Kerry, for that introduction. I'll try and be as quick as possible because we're running short of time. So we've talked a lot about hepatitis B since morning. Let me refocus your attention on hepatitis C for the next 10 minutes, please. Because hepatitis C, we live in a region where 9 out of 10 highest burden countries are in Asia Pacific. The only column that you see missing is Nigeria, which is Africa. Otherwise, everyone who's high in numbers is here in Asia Pacific. Pakistan has the dubious distinction of being the highest, as I mentioned yesterday, and therefore that is a problem. About 20,000 new cases of hepatitis of liver cancer every year, 25,000 annual deaths. That means one Pakistani dies every 20 minutes of hepatitis C at the moment. We have very little in terms of diagnosis. Only about 21% of hepatitis C patients have been diagnosed so far in the country. A few have been treated. We treated last year, for example, about 215,000 people. So lots of work that needs to be done. So what are we doing and what do we need to do about this? The CDA, which is Homi Razavi's organization, estimates to treat 1.2 million people and reduce new infections. We are adding new infections all the time, and therefore these numbers are not changing. So anywhere between 1.1 to 1.2 million people we need to treat every year. And in order to treat those number of people, we need to screen at least 14 million per year so that we are able to get hold of those 1.1 or 1.2 million people. Only then we can make something about the prevalence. I've mentioned earlier in these meetings that we have the tools to do this. And the biggest tool, enabling tool that we have is the extremely low cost of treatment for hepatitis C, which, as you can see on the slide, if we use mainly SOF and daclaritvir combination in our treatment regimens, both for the public and the private sector possibly, and that comes in at about $10 to $15 per month, which means for a 3-month course it will be under $50 that we can treat a patient who has no cirrhosis, for example. We know that this works. This is a multi-center or a multi-country study that we took part in. I highlight genotype 3 because genotype 3 is our 90% is our genotype 3, the so-called difficult to treat genotype. But even here we are doing not too bad, 91% on a intention to treat analysis and 97% cure rates in our per protocol analyses. So what have we proposed? This is what we have proposed to the government as part of the technical advisory group for the government of Pakistan. We call this document a PC1, which stands for Planning Commission 1, and that looks at different phases. So in the first phase, we propose to screen something like 69 million of population, which is aged above 12. Out of these screens, we will probably find about 5 million patients that will need treatment, and therefore, or at least 5 million people that will be positive, and 4 million people that will be viremic and will require treatment. Those are some of the steps that we have. So don't try and even read those. All I would tell you is the bottom line, which is that this program will cost something like 80 billion Pakistani rupees. That comes to around $350 million. That is really not a big price tag if you compare this to some other interventions or expenditures for the government, for example. So we have made an investment case multiple times to the government. And this is an example of this. There are many studies behind this, done from Bristol, from Homi Razavi's group, from other groups that have looked at this. And I think these figures are pretty reasonably solid. In order to end this, as I said, we need about $350 million. This would be something which is front-loaded, of course, because the biggest screening will come in the beginning, the biggest treatment will come in the beginning, but then we start to see the benefits on the right-hand side. You can see the benefits of non-hospitalization, reduced hospitalizations as you go along from 2023 to 2035. And the total, without NHEP, this is the total medical cost that will continue to accrue. So this the treatment, the screening and treatment for Pakistan becomes extremely cost effective very quickly. Within the initial first 3 to 4 years, it becomes effective. The plan is based on the government infrastructure, and this is what it looks like on paper. At least we have basic health units, we have rural health centers, district hospitals, and tertiary care hospitals, which are supposed to serve the population as a broad base in the basic health units, except the problem is the basic health units and the rural health centers do not function well. It is the district hospitals and the tertiary care hospitals that function well. Why is that? Because the funding all goes to the tertiary centers and the district hospitals and not to the rural centers, and therefore that is a difficulty for us. Having said that, there is a robust private setup, private medical system that is there, and this is an EMRO report looking at various EMRO countries. 77% of our population seeks ambulatory care in the private sector, and therefore, if we use the private sector, we are able to perhaps do this, and we can use the private sector in multiple ways. The initial one could be just to ask them to report these cases so that we have a good estimate of how many are being treated, how many are being screened. We can then decentralize many of these functions. So, for example, subsidizing free testing, then case notification. In some better centers, we can expand to even treatment and follow-up and so on. And in others, we can go the whole route of screening, testing, treating, and then follow-up as well. So this is doable. The WHO supports it so that these are the simplified versions of the delivery, the program delivery that WHO has considered. So clinically well and stable people can really be treated at primary care facilities. It's either, in fact, even a physician or a nurse can treat these people, can look after these patients. Some bit of training is required, but this can be done. So the facility-based hospitals are meant only for advanced liver disease then, and patients who need admissions and so on, and other special groups who require special interventions. The policy scenario is, and this is taken from the Lancet Commission published in 2019. I've highlighted Pakistan. If you look at this in terms of policy, we're not doing too badly. We have, so the green is where policy exists. It doesn't mean policy is implemented. It exists. There's a distinction. Please remember, the yellow is policies in development, and the red is no policy. So the only place that we do not have yet a policy is free birth dose vaccination. In fact, we now do have a policy for free birth dose vaccination. This goes back to 2019, as I said. So at the policy level, we're not doing too badly, but maybe at the implementation level, we are not doing too well. So we have effective tools to deal with this menace, and we can eliminate. We really need or miss the political drive, and that is where the frustration is. Some of you were there in 2019 in Islamabad on the World Hepatitis Day. which this year, it'll be 5 years from that, 4 years from that time. And nothing has happened. This is the president of the country. This is the health minister of that time from the country. He has just announced, we forced him to do this. He has just announced a mega program. Kerry was there. And the idea was to try and eliminate this within the WHO bounds of 2030. 2023, the needle hasn't moved. So please sense my frustration in all these aspects. The president of the country announced this and endorsed this. Thank you very much for your attention.
Thank you, Saeed. We want everyone to stay available for the panel discussion, which will follow Jack Wallace as a senior research officer and viral hepatitis elimination program at Burnett, but more importantly, a key member of CEVHAP. Ready to go? Jack, this is recorded, right? Thanks.
Hello, my name is Jack Wallace, and I'm a social researcher from the Burnett Institute in Melbourne, and am a founding and executive member of the Coalition to Eradicate Viral Hepatitis in Asia Pacific. The focus of this presentation is to look at some of the implications of hepatitis B cure science on the communities most affected by hepatitis B and some of the public health implications of hepatitis B cure science. In Australia, we generally start our meetings and presentation with an acknowledgement of country. This is to show my respect for the traditional owners of the land where I conducted the research and developed this presentation. My rationale for conducting this research was that I thought we needed to start to think about how a hepatitis B cure could be implemented, the possible challenges to the implementation, and to reframe hepatitis B cure as a public health issue. There are several reasons for this. The first is the increasing scientific and clinical interest in hepatitis B cure science and of an increasing number of hepatitis B cure clinical trials. My concern is that this increasing interest is occurring in a context where global elimination goals are not being met. At a global level, only 10% of people with Hep B have been diagnosed, and this number has barely changed over the past few years. A third issue is that hepatitis B is an asymptomatic infection, largely affecting lower and middle income countries, and where there are often significant social implications related to the infection. And lastly, we have the experience of a Hep C cure that is currently available and where there are still immense challenges in ensuring that people with hepatitis C actually access this cure. Exploratory semi-structured interviews were held with 31 professional stakeholders from across the world. They came with a range of expertise, which are listed on this slide, but we need to note that these classifications are not mutually exclusive. And probably all participants would have had some role in advocacy seeking to improve public health responses to hepatitis B. Several of these experts had lived experience of hepatitis B. I'm grateful to Peter Revel from the Doherty Institute for this slide that describes the science behind the cure. What it reflects is the specificity, complexity, and specialist nature of cure research. While this is one description of cure science, the stakeholders I spoke with talked of different descriptions and definitions. The International Coalition to Eliminate Viral Hepatitis describes two cures, a functional and a complete cure. These definitions have been determined by scientists without input from the people most affected by hepatitis B. The use of the phrase functional is interesting, and as one informant noted, what would a non-functional or dysfunctional cure look like? The biomedical description of hepatitis B is complex. Most people with hepatitis B, the recipients of the cure, are not biomedically trained, nor will they necessarily understand the nuance of words such as functional, particularly if they're going to be translated into languages other than English. We need to recognise that descriptions like functional cure will have unintended consequences among people with hepatitis B, let alone healthcare workers. This slide highlights different definitions of hepatitis B described by stakeholders coming from different professional backgrounds. The language and concepts used to describe hepatitis B cure differed dependent on this background. The last quote came from a person with hepatitis B who noted the social and legal impact of a cure rather than before the longer-term clinical impact. There are also a range of other definitions used: sterilising, true, eradicating, durable, absolute. None of them are necessarily contradictory, but they highlight that even among professionals, there are variations in defining the cure or what it could look like. While the language describing the cure differed depending on the knowledge and professional framework of the person talking about it, within many Asia-Pacific countries, hepatitis B has a significant impact over and beyond that of a medical condition. And the cure, and importantly how we describe the cure, has significant implications for the everyday lives of people with hepatitis B. It is a normal event within the region that people are tested and sometimes diagnosed with hepatitis B within workplaces, educational settings, and when applying for visas. And this essentially affects their life trajectory. Several participants talked of the social and practical implications that the cure would have on testing in non-healthcare settings and in accessing insurance. Looking now to some of the public health implications related to cure science. Discussing hepatitis B cure implementation means that public health professionals and planners can reframe and refocus hepatitis B interventions from a chronic infection to that of a curable disease. We can learn from public health responses to other bloodborne infections, including how the cure is made available, tablets, injections, or infusions. All of these issues essentially affect the scalability, implementation, and access of a cure. In Australia, there are a few barriers for people with hepatitis C to access their cure. The government has funded the cure for everybody with hepatitis C. Nevertheless, there are still challenges remaining in ensuring that everyone with hepatitis C accesses the cure, and that thinking ahead and preparing for the cure would have been useful. In countries where most people with hepatitis B are migrants, there are ethical and moral implications of the cure, particularly for people who receive the cure in one country, while their families who live overseas may be unable to access the cure. The cure will be implemented in environments in which other cures exist. Most people with hepatitis B are born in countries where traditional health interventions are probably easier, cheaper, and more accessible than biomedical interventions. The country with the largest number of people with hepatitis B is China, where traditional Chinese medicine has historical, political, and cultural significance. These issues make the choice to use a scientific cure much more complex. While the examples on the slide lack a certain sense of credibility, they make complete sense when you consider that most people with hepatitis B are poorly diagnosed, not provided with accurate or accessible information about hepatitis B, and have not been linked into services providing clinical care, alongside the deep social implications related to the infection. Success in delivering the cure not only relates to the drugs, but also the cultural and social context in which the cure is made available. Hepatitis B is a largely asymptomatic infection affecting people within the community whose lives are often not simple, and for whom an asymptomatic infection is one of their lower priorities. The cure will be used by communities who experience embedded and sometimes overt racism as an everyday occurrence. We know that the resources available at global and regional levels for hepatitis B do not reflect the mortality or burden of infection, with one participant highlighting racism as part of the reason for this. Where to next? Several participants noted hepatitis B as having a better chance of being eliminated than hepatitis C, given its vaccine and cure potential. A cure will be revolutionary, and it is worth thinking through its implementation, with this study being an initial and exploratory step. While cure science is slowly but steadily progressing, it will be for nothing unless the cure is scalable and accessible. Further work is needed to develop a framework for implementation, and this framework needs to cover issues such as availability, accessibility, acceptability, and quality. A cure helps change how we see hepatitis B as a public health and lived condition, and to better understand the challenges affecting hepatitis B elimination, as will integrating hepatitis B cure into national public health priorities. This research has been guided by the following, and I'm deeply grateful for their support with this project, and I'm looking forward to any questions. Thank you for your attention.
Okay, it looks like it's time for our panel discussion. We know we're running over a few minutes, but we'd like to continue this dialogue before the final closing from Professor Shina from Kyoto, which will be in a few minutes. Welcome. About 5 minutes, Professor. Looks like we have Jess online, Hong Dao and Ross. Fantastic.
Yeah.
Yep, Jack coming up to join us, and Saeed. Maybe get one more chair. Saeed, you want to join us up here? You okay? All right. I have one opening question, if that's okay. And should our focus be on hepatitis B and C screening first, and then focus later downstream on this issue about liver cancer risk and surveillance, or should we do this simultaneously? And maybe we'll go to Hong first, Jess second, and Ross third, if that's okay.
Yes, I'm here. Can you hear me clearly?
It's good, Hong.
Yeah, totally agree, because I think until now in Vietnam, we are still lacking of the national surveillance for the both for the viral hepatitis B, C, as well as the national program surveillance for the HCC in high-risk population. So as I said, for the prevention, for the first prevention strategy, to find out hepatitis patient is the first step that we have to perform. And because we have the high prevalence of HPV, so I think everyone in Vietnam should at least one time in their life should be tested for HPV.
Great. Jess, please.
Yeah, I think the same. I think a prevention approach for liver cancer is critical across the different etiologies. And I was very interested in the data from Malaysia at how that's changing. It's the same in Australia and many parts of the world. So a focus on prevention is critical, particularly when we're thinking of low resource settings where they don't necessarily have any treatments or even imaging access to diagnose HCC. The best approach and the first thing we should invest in is prevention at any cost, I think. And then moving into HCC surveillance and the different ways we can do that, leveraging some of the education and technologies that we develop in order to capture people and have people appropriately tested for liver disease that can lead to HCC.
I agree with Jess as well as Dao. I think really everything about early detection of HCC will go back to early detection of the risk factors. Then only this surveillance can start. And I think we need to look at the low-hanging fruit. And the low-hanging fruit, actually, a lot of effort is now being done for MAPLD. You can integrate a lot of these strategies on stratifying liver disease, which Jess has highlighted, is very much lacking. And that can apply when the primary care has actually learned how to do that. In also stratifying people with hepatitis B and have a lower threshold for treatment for hepatitis B as well. I think hepatitis C is a lot more straightforward. You have viremia, you treat. But for hepatitis B, it's not happening because people are not stratifying the liver disease stages.
Great comments. I was going to ask Dr. Hamid about the awareness of liver cancer in Pakistan on a public or patient level right now. Is this nominal or significant?
It is nominal. It is not significant. The diagnosis of hepatitis C is recognized as really as a death sentence. It's called black jaundice in normal terminology in our country, and that means black death basically. But that is the infection itself. It doesn't necessarily relate to liver cancer. So there is need to improve that area.
Syra, you want to introduce yourself?
Yeah. Hi, everyone. I'm Syra Kadri. I'm a hepatologist in Houston, Texas. Dr. Habib, I had just a couple of questions for you. I can't think of a better word than frustrated, but really the level is very clear of how much frustration you have, because 316 million, I know it's a lot of money, but it's really not to get a grip on Hep C in an entire country. So 2 questions. First, you mentioned even like treating Hep C is not enough. You have, because as you treat, new infections are there every day. So my first question was just what is the country doing to help prevent infection or ongoing infections? And 2 is what can people outside of Pakistan do to help?
So the 2 interventions that have happened and that are welcome are that our blood banks are now much more organized, and we hope that they are not transmitting anymore because they're testing well. The second intervention that has happened is that we are moving towards the single-use auto-destruct syringes. It is now, in fact, mandated by law. That is not uniformly implemented at the moment, but hopefully within the next 2 or 3 years, we will completely move towards auto-destruct syringes, and that will help a great deal in terms of prevention. Your second question was, what can people do sitting outside? The only plea is that you could raise some funds for us, or you could at least influence the people who have the money to raise funds for this project. These are peanuts for things like the World Bank, which also, by the way, bankrolled the Egyptian program. So there are avenues that can certainly be utilized.
And Jack, with your surveys that you've done about viral hepatitis, discrimination, et cetera, where does liver cancer fit into this? Is that a small issue? In the Hepatitis B Foundation, we find that dying from liver cancer is the biggest issue in the hepatitis B world.
And I'm kind of think, for me, and it kind of comes back to what Thomas and Lien were talking about, and Chari, was about the kind of impact. Most people with hepatitis B firstly haven't been diagnosed to start off with, that, less than 10%. So to find out that you've got hepatitis B is a bit of a success, really. Another thing is that families within this region have lived with liver cancer for generations. They know absolutely about liver cancer, but they may not know about it in terms of HCC or even liver cancer. They will know about it as black jaundice, which they also use that in Indonesia as well, that kind of framing. So it's a thing of terror, but it's also a thing where you're kind of a bit powerless, I think, to a certain degree. That if you don't know that you've got hepatitis B and that you're at risk of liver cancer, you're not going to do anything about it. So yeah, we're miles behind, really.
Gary?
Great. I think just one comment from me is I think, it's great for us to be talking here at a liver meeting about the connection between hepatitis B and liver cancer, but we really need the cancer people to be talking about the need to integrate hepatitis testing and treatment into their cancer strategies, right? And we've had some success for that in Europe. The European Union includes hepatitis as part of its cancer prevention strategy. And we work quite closely with the I always get the words in the wrong order. International Union of Cancer Control, which is a group of organizations, and they now include hepatitis vaccination as a cancer preventative vaccination as part of their ongoing advocacy. So I think that's really important for us. I think we really need to to mobilize all the resources available within health systems and within and within the cancer community, because when you start having a conversation about preventing cancer, it has a much different lilt on it than if you have a conversation about preventing hepatitis. And it includes a whole different range of stakeholders and a whole different range of funding opportunities. So I think with that, we'll close this session. And it's just my great pleasure and honor to introduce the incoming APASL president, Professor Sheena, who's professor at the Department of Gastroenterology. I did it right the first time at Jatendo University. Dr. Sheena, please. Yes.
Everybody needs to have Kyoto on their schedule for 1 year from now. We want to make a little advertisement.
Please, yeah. And so I'm Dr. Sheena of Japan. So first of all, I'd like to congratulate Professor Han-Shi Lin for his great success in the APASL 32nd annual meeting in Taipei. And next year, so I will have the annual meeting in Kyoto. And so, as you know, the Asia Pacific region has the world's largest population, and the more than 70% of the hepatitis B virus, virus are concentrated in this region. So we'd like to have the same session of the coalition of to eradicate hepatitis in Asia Pacific symposium next year. Okay, and so the term is March 27th to 31st next year, and the venue is International Conference Center in Kyoto, and so as you know, the Kyoto is the old capital of Japan, and this is the second annual meeting of APASL. We had the annual meeting in 2007. At that time, the president was Professor Masao Mata, and the venue is Kyoto International Conference Center. And this is the from up. The Kyoto International Conference Center has enough capacities to have the APASL annual meeting. And there are many hotels, and there are some awards. So Kyoto is a very cultural and traditional city. So we'd like to welcome you, all of you, with cherry blossoms in full bloom. At the end of March, we can enjoy the cherry blossoms in Kyoto. So see you in Kyoto. Thank you very much.
Thank you, everyone. Have a safe trip home.
I think maybe my only suggestion, I'll put it in an email, is for the 5 reasons why. I do think like mental health, quality of life, it's like kind of all comes in that kind of stigma one. Sure. So maybe the first one could be tweaked just a little bit, because it's for the benefit of the for the person, right? For their mental health, for their well-being, and so they don't suffer from stigma.
Well, I got a couple other comments. Well, that's
Yeah. Great, but thank you for doing that. It's so good.
Right, marketing message. Right?
Exactly. It's got to be easy to understand. All right. Good. Hi.
Yeah, basically 5-8.
Okay.
No, did we put a kids thing next week? Next week, younger?
We're based in London, yeah. The alliance is registered and put them in the spread the laws. Okay, yeah, good, yeah. What we do. Oh, you on mute? Yeah. Working 80 hours a week, so. No. That's bad. Yeah. I'm going to respond to your email. I need to think more about it because there's maybe if it needs to be another aspect. Yeah. Oh, good. No, and it's a really kind of good, perhaps simplified to, I've been worried about